Cardinal function, the exchange of gases between inspired air and blood. Developmentally, the respiratory system is an outgrowth from the ventral wall of the foregut. The midline trachea develops two lateral outpocketings, the lung buds, which eventually divide into branches called lobar bronchi, 3 on the right and 2 on the left, thus giving rise to 3 lobes on the right and 2 on the left. The lobar bronchi allow air to pass in and out of the lung. They have firm cartilaginous walls that provide mechanical support and are lined by columnar ciliated epithelium with abundant subepithelial glands that produce mucus, which impedes the entry of microbes. The right mainstem bronchus is more vertical and directly in line with the trachea. Consequently, aspirated foreign materials such as vomitus, blood, and foreign bodies tend to enter the right lung more often than the left. The right and left lobar bronchi branch to give rise to progressively smaller airways that are accompanied by a dual arterial supply from the pulmonary and bronchial arteries. Distally, the bronchi give way to bronchioles, which are distinguished by the lack of cartilage and the presence of submucosal glands within their walls. Further branching. 476 Repoc 51 AT GNU L. A bronchioles leads to the terminal bronchioles, which are less than 2 mm in diameter. Beyond the terminal bronchiole is the acinus, a roughly spherical structure with a diameter of about 7 mm. An acinus is composed of a respiratory bronchiole which gives off several alveoli from its sides, alveolar ducts, and alveolar sacs, the blind ends of the respiratory passages, whose walls are formed entirely of alveoli, the site of gas exchange. A cluster of 3 to 5 terminal bronchioles, each with its appended acinus, is referred to as the pulmonary lobule. Except for the true vocal cords, which are covered by stratified squamous epithelium, the entire respiratory tree, including the larynx, trachea, and bronchioles, is normally lined mainly by tall, columnar, pseudostratified, ciliated epithelial cells and a smaller population of non-ciliated cells called club cells that secrete a number of protective substances into the airway. There also are scattered cells called ionocytes that express high levels of the cystic fibrosis transmembrane conductance regulator CFTR and appear to modulate the ion content and viscosity of bronchial secretions. In addition, the bronchial mucosa contains neuroendocrine cells with neurosecretory type granules that can release a variety of factors including serotonin, calcitonin, and gastrin-releasing peptide bomycin. Numerous mucus-secreting goblet cells and submucosal glands also are dispersed throughout the walls of the trachea and bronchi, but not the bronchioles. The microscopic structure of the alveolar walls or alveolar septa consists of the following Fig. 15.1. An intertwining network of anastomose and capillaries lined with endothelial cells. Basement membrane and surrounding interstitium, which separates the endothelial cells from the alveolar lining epithelial cells. In thin portions of the alveolar septum, the basement membranes of epithelium and endothelium are fused, whereas in thicker portions they are separated by an interstitial space pulmonary interstitium containing fine elastic fibers, small bundles of collagen, a few fibroblasts-like interstitial cells, smooth muscle cells, mast cells, and rare lymphocytes and monocytes. Type Roman II pneumocyte, alveolar space. Type I pneumocyte, endothelium interstitial. Cell capillary. Lumen. Type I pneumocyte, alveolar space. Endothelium. Figure 15.1 microscopic structure of the alveolar wall. Note that the basement membrane yellow is thin on one side and white where it is continuous with the interstitial space. Portions of interstitial cells are shown. Alveolar epithelium, a continuous layer of 2 cell types, flat, plate-like type I pneumocytes, covering 95% of the alveolar surface, and rounded type Roman II pneumocytes. Type Roman II cells synthesize surfactant which forms a very thin layer over the alveolar cell membranes and are involved in the repair of alveolar damage through their ability to proliferate and give rise to type I cells. The alveolar walls are perforated by numerous pores of cone, which permit the passage of bacteria and exudate between adjacent alveoli. See Fig. 15.35b. Scattered resident alveolar macrophages also are present, either loosely attached to epithelial cells or lying free within the alveolar spaces. Congenital anomalies. Developmental anomalies of the lung are rare. The most common of these include the following. Pulmonary hypoplasia is a defect in the development of both lungs. One may be more affected than the other that results in decreased lung size. It is caused by abnormalities that compress the lung or impede lung expansion in utero, such as congenital diaphragmatic hernia and oligohydramnios. Severe hypoplasia is fatal in the early neonatal period. Foregut cysts arise from abnormal detachments of primitive foregut and are most often located in the hilum or middle mediastin. Depending on the wall structure, these cysts are classified as bronchogenic, most common, esophageal, or enteric. Bronchogenic cyst is rarely connected to the tracheobronchial tree. It is lined by ciliated pseudostratified columnar epithelium and has a wall containing bronchial glands, cartilage, and smooth muscle. It may come to attention due to symptoms resulting from compression of nearby structures or superimposed infection, or may be incidental findings. Pulmonary sequestration is a discrete area of lung tissue that, 1, is not connected to the airways and 2, has an abnormal blood supply rising from the aorta or its branches. Extralobar sequestration is external to the lung and most commonly present in infants as a mass lesion. It may be associated with other congenital anomalies. Intralobar sequestration occurs within the lung. It usually presents in older children, often due to recurrent localized infections or bronchitis. Other, less common congenital abnormalities include tracheal and bronchial anomalies, atresia, stenosis, tracheoesophageal fistula, vascular anomalies, congenital pulmonary airway malformation, and congenital lobar overinflation emphysema. Atelectasis collapse. Atelectasis refers either to incomplete expansion of the lungs, neonatal atelectasis, or to the collapse of previously inflated lung, and results in areas of poorly aerated pulmonary parenchyma. The main types of acquired atelectasis, which is encountered principally in adults, are the following. Fig. 15.2. Ammonia 576 pain. Pulmonary edema or increased capillary permeability due to microvascular injury, non-cardiogenic pulmonary edema. Table 15.1. General consideration of edema is given in Chapter 4, and pulmonary congestion and edema are described briefly in the context of congestive heart failure, Chapter 12. Whatever the clinical setting, pulmonary congestion and edema produce heavy, wet lungs, Therapy and outcome depend on the underlying etiology. Hemodynamic pulmonary edema. Absorption compression. Hemodynamic pulmonary edema is caused by increased hydrostatic pressure and occurs most commonly in left-sided congestive heart failure. Edema accumulates initially in the basal regions of the lower lobes because hydrostatic pressure is greatest in these sites-dependent edema. Histologically, the alveolar capillaries are engorged, and there is an intra-alveolar transudate that appears as finely granular pale pink material. Alveolar microhemorrhages and hemosider and latent macrophages heart failure cells may be present. In long-standing pulmonary congestion, for example, as seen in mitral stenosis, hemosider and latent macrophages are abundant, and fibrosis and thickening of the alveolar walls cause the soggy lungs to become firm and brown in duration. These changes not only impair respiratory function but also predispose to infection. Contraction. Figure 15.2 Various forms of acquired atelectasis. Dashed lines indicate normal lung volume. Absorption atelectasis stems from obstruction of an airway. Over time, air is resorbed from distal alveoli, which collapse. Since lung volume is diminished, the mediastinum shifts toward the atelectatic line. Airway obstruction is most often caused by excessive secretions, for example, mucus plugs or exudates within smaller bronchi, as may occur in bronchial asthma, chronic bronchitis, bronchiectasis, and postoperative states. Aspiration of foreign bodies and intrabronchial tumors may also lead to airway obstruction and atelectasis. Compression atelectasis results whenever significant volumes of fluid transudate, exudate, or blood, tumor, or air pneumothorax accumulate within the pleural cavity. With compression atelectasis, the mediastinum shifts away from the affected lung. Contraction atelectasis occurs when focal or generalized pulmonary or pleural fibrosis prevents full lung expansion. Significant atelectasis reduces oxygenation and predisposes to infection. Except in cases caused by fibrosis, atelectasis is a reversible disorder. Pulmonary edema. Pulmonary edema, excessive interstitial fluid in the alveoli, can result from hemodynamic disturbances cardiogenic. T15.1 and causes of pulmonary edema of hemodynamic edema, increased hydrostatic pressure, increased pulmonary venous pressure. Left-sided heart failure, common volume overload, pulmonary vein obstruction. Decreased oncotic pressure, less common. Hypoalbuminemia, nephrotic syndrome, liver disease, protein losing enteropathies. Lymphatic obstruction, rare. Edema due to alveolar wall injury, microvascular or epithelial injury. Direct injury. Infections, bacterial pneumonia, inhaled gases. High concentrations of oxygen, smoke liquid aspiration, gastric contents, near drowning, radiation, lung trauma. Indirect injury, systemic inflammatory response syndrome, for example, associated with sepsis, burns, pancreatitis, extensive trauma, blood transfusion, related. Drugs and chemicals, chemotherapeutic agents, bleomycin, other medications, methadone, amphotericin B, heroin, cocaine, kerosene, paraquat, edema of undetermined origin. High-altitude neurogenic central nervous system trauma classification. 676, Chapter 15, the lung. Edema caused by microvascular alveolar injury. Non-cardiogenic pulmonary edema is caused by injury of the alveolar septum. Primary injury to the vascular endothelium or damage to alveolar epithelial cells with secondary microvascular injury produces an inflammatory exudate that leaks into the interstitial space and, in more severe cases, into the alveoli. Injury-related alveolar edema is an important feature of a serious and often fatal condition, acute respiratory distress syndrome, discussed below. Acute lung injury and acute respiratory distress syndrome diffuse alveolar damage. Acute lung injury ALI is characterized by the abrupt onset of hypoxemia and bilateral pulmonary edema in the absence of cardiac failure. Non-cardiogenic pulmonary edema. Acute respiratory distress syndrome ARDS is a manifestation of severe ALI. Both ARDS and ALI are associated with inflammation-associated increases in pulmonary vascular permeability, edema, and epithelial cell death. The histologic manifestation of these diseases is diffuse alveolar damage. ALI is a well-recognized complication of diverse conditions, including both pulmonary and systemic disorders, Table 15.2. In many cases, several predisposing conditions are present, for example, shock, oxygen therapy, and sepsis. In other uncommon instances, ALI appears acutely in the absence of known triggers and follows a rapidly progressive clinical course, a condition known as acute interstitial pneumonia. Pathogenesis ALI/ARDS is initiated by injury of pneumocytes in pulmonary endothelium, setting in motion a vicious cycle of increasing inflammation and pulmonary damage. Fig. 15.3. Endothelial activation is an important early event. In some instances, endothelial activation is secondary to pneumocyte injury, which is sensed by resident alveolar macrophages. In response, these immune sentinels secrete mediators such as tumor necrosis factor TNF that act on the neighboring endothelium. Alternatively, circulating inflammatory mediators may activate pulmonary endothelium directly in the setting of severe tissue injury or sepsis. Some of these mediators injure endothelial cells, while others, notably cytokines, induce endothelial cells to express increased levels of adhesion molecules, procoagulant proteins, and chemokines. Adhesion and extravasation of neutrophils. Neutrophils adhere to the activated endothelium and migrate into the interstitium and the alveoli, where they degranulate and release inflammatory mediators including proteases, reactive oxygen species, and cytokines. Experimental evidence suggests that neutrophil extracellular traps nets are released and also contribute directly to lung damage. These injuries and associated pro-inflammatory factors set in motion a vicious cycle of inflammation and endothelial damage that lies at the heart of ALI/ARDS. Associated with DMTOF, Table 1 of FIVEP, L12 conditions, respiratory distress syndrome, infection, sepsis and diffuse pulmonary infections, viral, mycoplasma, and pneumocystis pneumonia, miliary tuberculosis, gastric aspiration. Physical/injury, mechanical trauma including head injury, pulmonary contusions, near drowning, fractures with fat embolism, burns, ionizing radiation, inhaled irritants. Oxygen toxicity, smoke, irritant gases, and chemicals. Chemical injury, heroin or methadone overdose, acetylsalicylic acid barbiturate overdose, paraquat. Hematologic conditions. Transfusion-associated lung injury, trolley-disseminated intravascular coagulation, pancreatitis, uremia, cardiopulmonary bypass, hypersensitivity reactions. Organic solvents, drugs. More than 50% of cases of acute respiratory distress syndrome are associated with these four conditions. Acute, accumulation of intra-alveolar fluid, inflammation of hyaline membranes. Endothelial activation and injury make pulmonary capillaries leaky, allowing interstitial and intra-alveolar edema fluid to form. Damage and necrosis of type Roman II alveolar pneumocytes lead to surfactant abnormalities, further compromising alveolar gas exchange. Ultimately, the unspissated protein-rich edema fluid and debris from dead alveolar epithelial cells organize into hyaline membranes, a characteristic feature of ALI/Rs. Resolution of injury is impeded in ALI/Rs due to epithelial necrosis and inflammatory damage that impairs the ability of remaining cells to assist with edema resorption. Eventually, however, if the inflammatory stimulus lessens, macrophages remove intra-alveolar debris and release fibrogenic cytokines such as transforming growth factor beta, TGF-beta, and platelet-derived growth factor. These factors stimulate fibroblast growth and collagen deposition, leading to fibrosis of alveolar walls. Residual type Roman II pneumocytes proliferate to replace type I pneumocytes, reconstituting the alveolar lining. Endothelial restoration occurs through proliferation of uninjured capillary endothelium. Lung injury and acute respiratory distress syndrome, diffuse alveolar damage 677. Normal alveolus acute lung injury. Bronchial epithelium, slough bronchial epithelium. Basement membrane. Inactivated surfactant necrotic type I cell. Alveolar macrophage ROS. Cytokines, proteases, edema fluid. Surfactant layer, type I cell. Capillary, type Roman II cell. Interstitium, alveolus. TNF-IL1, TNF chemokines. Fibrin, hyaline membrane. Fibroblasts, procollagen. Cellular debris, neutrophil sequestration and migration into alveolus. Edema, endothelial cell injured, swollen. Endothelial cells. Figure 15.3. The normal alveolus left side compared with the injured alveolus in the early phase of acute lung injury and acute respiratory distress syndrome. The 1, interleukin-1, ROS, reactive oxygen species, TNF, tumor necrosis factor, modified with permission from MA, wet LB, Zimmerman GA. The acute respiratory distress syndrome, J. Clin Invest to Event 2731, 2012. The lesions in Rs are not evenly distributed, and as a result there are typically areas that are stiff and poorly aerated and regions that have nearly normal levels of compliance and ventilation. Because poorly aerated regions continue to be perfused, there is a mismatch of ventilation and perfusion, a phenomenon that exacerbates the hypoxemia and cyanosis. Epidemiologic studies have shown that ALI/Rs is more common and has a worse prognosis in chronic alcoholics and in smokers. Genome-wide association studies have identified a number of genetic variants that increase the risk of Rs, some of which map to genes linked to inflammation and coagulation. Organizing stage. Type Roman II pneumocytes proliferate and granulation tissue forms in the alveolar walls and spaces. In most cases, the granulation tissue resolves, leaving minimal functional impairment. Sometimes, however, fibrotic thickening scarring of the alveolar septa ensues late fibrotic stage, acute. Morphology in the acute exudative stage. The lungs are heavy, firm, red, and boggy. They exhibit congestion, interstitial and intra-alveolar edema, inflammation, fibrin deposition, and diffuse alveolar damage. The alveolar walls become lined with waxy hyaline membranes, Fig. 15, 4, that are morphologically similar to those seen in hyaline membrane disease of neonates, Chapter 10. Alveolar hyaline membranes consist of fibrin-rich edema fluid mixed with the remnants of necrotic epithelial cells. In the proliferative or Figure 15.4 diffuse alveolar damage acute respiratory distress syndrome. Some of the alveoli are collapsed, while others are distended. Many are lined by hyaline membranes arrows. 678 Chapter 15 The lung. Clinical features profound dyspnea and tachypnea herald ALI/Rs, followed by increasing respiratory failure, hypoxemia, cyanosis, and the appearance of diffuse bilateral infiltrates on radiographic examination. Hypoxemia may be refractory to oxygen therapy due to ventilation-perfusion mismatch, and respiratory acidosis can develop. Early in the course, the lungs become stiff due to loss of functional surfactant, leading to the need for intubation and high ventilatory pressures to maintain adequate gas exchange. There are no proven specific treatments for Rs, which is common in acutely ill patients and continues to take a high toll, even in patients receiving state-of-the-art supportive care. In a 2016 study of intensive care units in 50 countries, the incidence of Rs was 4%, and mortality rates were 35% for mild, 40% for moderate, and 46% for severe Rs. The majority of deaths are attributable to sepsis, multi-organ failure, or severe lung injury. Most survivors recover pulmonary function, but in a minority of patients, the lung damage results in interstitial fibrosis and chronic pulmonary disease. Key concepts: acute respiratory distress syndrome. Rs is a clinical syndrome of progressive respiratory insufficiency caused by diffuse alveolar damage in the setting of sepsis, severe trauma, or diffuse pulmonary infection. Damage to endothelial and alveolar epithelial cells and secondary. Inflammation are the key initiating events and the basis of lung damage. The characteristic histologic finding is hyaline membranes lining alveolar walls, accompanied by edema, scattered neutrophils, and macrophages, and epithelial necrosis. Obstructive and restrictive lung diseases. Obstructive lung diseases are characterized by an increase in resistance to airflow due to diffuse airway disease, which may affect any level of the respiratory tract. These are contrasted with restrictive diseases, which are characterized by reduced expansion of lung parenchyma and decreased total lung capacity. The clinical distinction between these diseases is based primarily on pulmonary function tests. In individuals with diffuse obstructive disorders, pulmonary function tests show decreased maximal airflow rates during forced expiration, usually expressed as forced expiratory volume at 1 second FEV1 over forced ventilatory capacity FVC. FEV1/FVC ratio of less than 0.7 generally indicates obstructive disease. Expiratory airflow obstruction may be caused by a variety of conditions. Table 15. 3, each with characteristic pathologic changes and different mechanisms of airflow obstruction. As discussed later, however, the divisions between these entities are not clean, and many patients have diseases with overlapping features. By contrast, restrictive diseases are associated with proportionate decreases in both total lung capacity and FEV volume, such that the FEV volume/FVC ratio remains normal. Restrictive defects occur in two broad kinds of conditions: one, chest wall disorders, for example, severe obesity, pleural diseases, kyphoscoliosis, and neuromuscular diseases such as poliomyelitis, and two, chronic interstitial and infiltrative diseases, such as pneumoconiosis and interstitial fibrosis. Obstructive lung diseases. Common obstructive lung diseases include chronic obstructive pulmonary disease, COPD, asthma, and bronchitis, Table 15.3. COPD has two major clinical pathologic manifestations, emphysema and chronic bronchitis, which are often found together in the same patient, almost certainly because they share the same major etiologic factor: cigarette smoking. While asthma is distinguished from chronic bronchitis and emphysema by the presence of reversible bronchospasm, some patients with otherwise typical asthma also develop an irreversible component, Fig. 15.5. Conversely, some patients with otherwise typical COPD have a reversible component. Clinicians commonly label such patients as having COPD/asthma. Chronic obstructive pulmonary disease. COPD, a major public health problem, is defined by the World Health Organization as a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities caused by exposure to noxious particles or gases. It is currently the fourth. Table 15.3. Disorders associated with airflow obstruction. The spectrum of chronic obstructive pulmonary disease. Clinical term: anatomic site, major pathologic changes, etiology, signs/symptoms: chronic bronchitis, bronchus, mucus gland hyperplasia, tobacco smoke, air cough, sputum production. Hypersecretion pollutants, bronchitis, bronchus, airway dilation and scarring, persistent or severe cough, virulent sputum, infections, fever, asthma, bronchus, smooth muscle hyperplasia, immunologic or undefined episodic wheezing, cough. Excess mucus, inflammation causes dyspnea. Emphysema, sinus airspace enlargement, wall, tobacco smoke, dyspnea. Destruction, small airways disease, bronchial inflammatory scarring/obliteration, tobacco smoke, air cough, dyspnea, bronchiolitis, pollutants, miscellaneous. Can be seen with any form of obstructive lung disease or as an isolated finding. Obstructive lung disease is 679. Emphysema, alveolar wall destruction, overinflation. Chronic injury, for example, smoking. Small airway disease, asthma, reversible obstruction, bronchial hyperresponsiveness triggered by allergens, infection, etc. Figure 15.5. Schematic representation of overlap between chronic obstructive lung diseases. Leading cause of death in the world and is projected to rank third by 2020 due to increases in cigarette smoking in countries such as China. There is a strong association between heavy cigarette smoking and COPD. Overall, 35% to 50% of heavy smokers develop COPD. Conversely, about 80% of COPD is attributable to smoking. Women and African Americans who smoke heavily are more susceptible than other groups. Additional risk factors include poor lung development early in life, exposure to environmental and occupational pollutants, airway hyperresponsiveness, and certain genetic polymorphisms. Recognizing that emphysema and chronic bronchitis often occur together in patients with COPD, it is still useful to discuss these patterns of lung injury and associated functional abnormalities individually to highlight the pathophysiologic basis of different causes of airflow obstruction. We will finish our discussion by returning to the clinical features of COPD. Emphysema is defined by irreversible enlargement of the airspaces distal to the terminal bronchiole, accompanied by destruction of their walls. Subtle but functionally important small airway fibrosis distinct from chronic bronchitis is also present and is a significant contributor to airflow obstruction. Emphysema is classified according to its anatomic distribution within the lobule. Recall that the lobule is a cluster of acini, the terminal respiratory units. Based on the segments of the respiratory units that are involved, emphysema is subdivided into four major types: 1 centroacinar, 2 panacinar, 3 paraseptal, and 4 irregular. Of these, only the first two cause clinically significant airflow obstruction. Fig. 15.6. Centroacinar centrolobular emphysema. Centroacinar emphysema is the most common form, constituting more than 95% of clinically significant cases. It occurs predominantly in heavy smokers with COPD. In this type of emphysema, the central or proximal parts of the acini, formed by respiratory bronchioles, are affected, whereas distal alveoli are spared. Figs. 15.6b and 15.7a. Thus, chronic bronchitis, productive cough, airway inflammation. Both emphysematis and normal airspaces exist within the same acinus and lobule. The lesions are more common and usually more pronounced in the upper lobes, particularly in the apical segments. A severe centroacinar emphysema, the distal acinus may also be involved, making differentiation from panacinar emphysema difficult. Panacinar panlobular emphysema. Panacinar emphysema is associated with alpha-1 antitrypsin deficiency, chapter 18, and is exacerbated by smoking. In this type, the acini are uniformly enlarged from the level of the respiratory bronchiole to the terminal blind alveoli. Figs. 15.6c and 15.7b. In contrast to centroacinar emphysema, panacinar emphysema tends to occur more commonly in the lower zones and in the anterior margins of the lung, and it is usually most severe at the bases. Distal acinar paraseptal emphysema. Distal acinar emphysema probably underlies many cases of spontaneous pneumothorax in young adults. In this type, the proximal portion of the acinus is normal, and the distal part is predominantly involved. The emphysema is more striking adjacent to the pleura, along the lobular connective tissue septa, and at the margins of the lobules. It occurs adjacent to areas of fibrosis, scarring, or atelectasis, and is usually more severe in the upper half of the lungs. The characteristic finding is multiple enlarged airspaces, ranging from less than 0.5 cm to more than 2.0 cm in diameter, which sometimes form cyst-like structures. alveolus, normal sinus, respiratory bronchoalveolar duct, AC, alveolus, B, respiratory, bronchoalveolar duct, penisinnar emphysema, centriacinar emphysema. Figure 15.6 clinically significant patterns of emphysema, a structure of the normal sinus. B, centriacinar emphysema with dilation that initially affects the respiratory bronchioles. C, penisinnar emphysema with initial distension of the alveolus and alveolar duct. 680 Chapter 15 The lung. E, figure 15.7 a centriacinar emphysema. Central areas show marked emphysematous damage, E, surrounded by relatively spared alveolar spaces. E, penisinnar emphysema involving the entire pulmonary lobule. Airspace enlargement with fibrosis. Irregular emphysema. Irregular emphysema, so named because their sinus is irregularly involved, is almost invariably associated with scarring. In most instances, it occurs in small foci and is clinically insignificant. Pathogenesis. Clinically significant emphysema is largely confined to smokers and to patients with alpha-1 antitrypsin deficiency, highlighting the importance of these two etiologic factors. Mechanisms relating to these factors that contribute to the development of emphysema include the following: 15.8 toxic injury and inflammation. Inhaled cigarette smoke and other noxious particles damage respiratory epithelium and cause inflammation, which results in variable degrees of parenchymal destruction. A wide variety of inflammatory mediators, including leukotriene B4, interleukin IL-8, TNF, and others are increased in the affected parts of the lung. These mediators are released by resident epithelial cells and macrophages and variously attract inflammatory cells from the circulation. Chemotactic factors amplify the inflammatory process, pro-inflammatory cytokines, and induce structural changes, growth factors. Chronic inflammation also leads to the accumulation of TMB, smoking or air pollutant, plus genetic predisposition, congenital 1 antitrypsin deficiency, oxidative stress, increased apoptosis and senescence, inflammatory cells, release of inflammatory mediators, protease-interprotease imbalance, alveolar wall destruction. Figure 15.8 pathogenesis of emphysema. See text for details. Cells in affected parts of the lung, but the role of adaptive immunity in emphysema is currently uncertain. Protease-interprotease imbalance. Several proteases are released from the inflammatory cells and epithelial cells that break down connective tissue components. In patients who develop emphysema, there is a relative deficiency of protective antiproteases, which in some instances has a genetic basis discussed later. Oxidative stress. Substances in tobacco smoke, alveolar damage, and inflammatory cells all produce oxidants, which may beget tissue damage, endothelial dysfunction, and inflammation. The role of oxidants is supported by studies of mice in which the NRF2 gene is inactivated. NRF2 is a transcription factor that serves as a sensor for oxidants in many cell types, including alveolar epithelial cells. Intracellular oxidants activate NRF2, which upregulates the expression of genes that protect cells from oxidant damage. Mice without NRF2 are significantly more sensitive to tobacco smoke than normal mice, and genetic variants in NRF2, NRF2 regulators, and NRF2 target genes are all associated with smoking-related lung disease in humans. Infection. Although infection is not thought to play an initiating role in the tissue destruction, bacterial and/or viral infections may acutely exacerbate existing disease. The idea that proteases are important is based in part on the observation that patients with a genetic deficiency of the antiprotease alpha-1 antitrypsin have a markedly enhanced tendency to develop emphysema that is compounded by smoking. About 1% of all patients with emphysema have this defect. Alpha-1 antitrypsin, normally present in serum, tissue fluids, and macrophages, is a major inhibitor of proteases, particularly elastase secreted by neutrophils during inflammation. It is encoded by the proteinase inhibitor pi locus on chromosome 14. The pi locus is polymorphic, and approximately 0.12% of the U.S. population is homozygous for the Z allele, a genotype associated with very low serum levels of alpha-1 antitrypsin. More than 80% of ZZ individuals develop symptomatic panisinnar emphysema, which occurs at an earlier age and is of greater severity if the individual smokes. It is postulated that any injury, for example, that induced by smoking that increases the activation and influx of obstructive lung disease is 681. Neutrophils into the lung leads to local release of proteases, which in the absence of alpha-1 antitrypsin activity result in excessive digestion of elastic tissue and, with time, emphysema. Several other genetic variants have also been linked to risk of emphysema. Among these are variants of the nicotinic acetylcholine receptor that are hypothesized to influence the addictiveness of tobacco smoke and thus the behavior of smokers. Not surprisingly, the same variants are also linked to lung cancer risk, emphasizing the importance of smoking in both of these diseases. A number of factors contribute to airway obstruction and emphysema. Small airways are normally held open by the elastic recoil of the lung parenchyma. The loss of elastic tissue in the walls of alveoli that surround respiratory bronchioles reduces radial traction, leading to collapse of respiratory bronchioles during expiration and functional airflow obstruction in the absence of mechanical obstruction. In addition, even young smokers often have changes related to small airway inflammation that also contribute to airway narrowing and obstruction described later. Morphology. Advanced emphysema produces voluminous lungs, often overlapping the heart anteriorly. Generally, in patients with smoking-related disease, the upper two-thirds of the lungs are more severely affected. Large alveoli can easily be seen on the cut surface of fixed lungs. See Fig. 15. 7. Apical blebs or bully, characteristic of irregular emphysema, may appear in patients with advanced disease. Microscopically, abnormally large alveoli are separated by thin septa with focal centriacinar fibrosis. There is loss of attachments between alveoli and the outer wall of small airways. The pores of cone are so large that septa appear to be floating or protrude blindly into alveolar spaces with a club-shaped end. As alveolar walls are destroyed, there is a decrease in the capillary bed area. With advanced disease, there are even larger abnormal air spaces and possibly blebs or bulli, which often deform and compress the respiratory bronchioles and vasculature of the lung. Inflammatory changes in small airways are often superimposed, described next under chronic bronchitis, as are vascular changes related to pulmonary hypertension stemming from local hypoxemia. and loss of capillary beds. Chronic bronchitis. Chronic bronchitis is defined clinically as persistent cough with sputum production for at least 3 months and at least 2 consecutive years in the absence of any other identifiable cause. Longstanding chronic bronchitis is associated with progressive lung dysfunction, which may be so severe as to lead to hypoxemia, pulmonary hypertension, and cor pulmonale. Pathogenesis. The primary or initiating factor in the genesis of chronic bronchitis is exposure to noxious or irritating inhaled substances such as tobacco smoke. 90% of those affected are smokers, and dust from grain, cotton, and silica. Several factors contribute to its pathogenesis. Mucus hypersecretion. The earliest feature of chronic bronchitis is hypersecretion of mucus in the large airways, associated with enlargement of the submucosal glands in the trachea and bronchi. The basis for mucus hypersecretion is incompletely understood, but it appears to involve inflammatory mediators such as histamine and IL-13. With time, there is also a marked increase in goblet cells in small airways, small bronchi and bronchioles, leading to excessive mucus production that contributes to airway obstruction. It is thought that both the enlargement of submucosal glands and the increase in numbers of goblet cells are protective reactions against tobacco smoke or other pollutants, for example, sulfur dioxide and nitrogen dioxide. Acquired cystic fibrosis transmembrane conductance regulator, CFTR, dysfunction. There is substantial evidence that smoking leads to acquired CFTR dysfunction, which in turn causes the secretion of abnormal, dehydrated mucus that exacerbates the severity of chronic bronchitis. Inflammation. Inhalants that induce chronic bronchitis cause cellular damage, eliciting both acute and chronic inflammatory responses involving neutrophils, lymphocytes, and macrophages. Long-standing inflammation and accompanying fibrosis involving small airways, small bronchi, and bronchioles, less than 2 to 3 mm in diameter, can also lead to chronic airway obstruction. Infection. Infection does not initiate chronic bronchitis, but is probably significant in maintaining it and may be critical in producing acute exacerbations. Cigarette smoke predisposes to chronic bronchitis in several ways. Not only does it damage airway lining cells, leading to chronic inflammation, but it also interferes with the ciliary action of the respiratory epithelium, preventing the clearance of mucus and increasing the risk of infection. Morphology. Grossly, there is hyperemia, swelling, and edema of the mucous membranes, frequently accompanied by excessive mucinous or mucopurulent secretions. Sometimes, heavy casts of secretions and pus fill the bronchi and bronchioles. The characteristic microscopic features are chronic inflammation of the airways, predominantly lymphocytes and macrophages, thickening of the bronchiolar wall due to smooth muscle hypertrophy, deposition of extracellular matrix in the muscle layer, and parabronchial fibrosis, goblet cell hyperplasia, and enlargement of the mucus-secreting glands of the trachea and bronchi. Of these, the most striking change is an increase in the size of the mucus glands. This increase can be assessed by the ratio of the thickness of the mucus gland layer to the thickness of the wall between the epithelium and the cartilage. Reed index. The Reed index, normally 0.4, is increased in chronic bronchitis, usually in proportion to the severity and duration of the disease. The mucus plugging, inflammation, and fibrosis may lead to marked narrowing of bronchioles, and in the most severe cases, there may be obliteration of lumen due to fibrosis bronchiolitis obliterans. Bronchial epithelium may also exhibit squamous metaplasia and dysplasia due to the irritating and mutagenic effects of substances in tobacco smoke. Clinical features of COPD. Most affected patients have a smoking history of 40 pack years or greater. COPD often presents insidiously with slowly. 682 Chapter 15. The lung. 15. MT4. Age, years, dyspnea, cough, infections, respiratory insufficiency, cor pulmonale, airway resistance, elastic recoil, chest radiograph, appearance, Röntgen table itis, features of emphysema. Bronchitis. 40, 45, mild, late, early, copious sputum, common, early, periodic, common, increase, normal, prominent vessels, large heart size, blue bloater, increasing dyspnea on exertion and chronic cough with sputum production, slight at first but increasing over time. Other patients present with exacerbations caused by superimposed infection that can lead to confusion with other disorders, such as asthma due to wheezing. The most important diagnostic test is spirometry, which typically shows an FeV1/FVC ratio of less than 0.7. Once COPD appears, symptoms often wax and wane over time and are generally worse in the morning. The clinical picture varies according to the severity of the disease and the relative contributions of emphysematis and bronchitic changes. Table 15.4. At one extreme end of the spectrum lie pink puffers, patients in whom emphysema dominates. Classically, the patient is barrel-chested and dyspneic, with obviously prolonged expiration, sits forward in a hunched-over position, and breathes through pursed lips. Cough is often slight, overextension of the lungs is severe, diffusion capacity is low, and blood gas values are relatively normal at rest. Weight loss is common and can be so severe as to suggest an occult cancer. At the other end lie patients with pure chronic bronchitis, ingloriously referred to as blue bloaters. Their cardinal symptom is a persistent cough productive of sputum, coupled with hypercapnia, hypoxemia, and mild cyanosis. Most patients are somewhere in the middle, with signs and symptoms stemming from both bronchitic and emphysematic changes. Treatment options include smoking cessation, oxygen therapy, long-acting bronchodilators with inhaled corticosteroids, antibiotics, physical therapy, colectomy, and, in selected patients, lung volume reduction surgery and lung transplantation. Even with intervention, however, COPD often progresses and frequently proves fatal. Long-standing COPD, particularly in patients with a bronchitic component, commonly leads to pulmonary hypertension, cor pulmonale, and death due to heart failure. Death may also result from acute respiratory failure due to acute infections superimposed on COPD. In patients with emphysematic changes, subpleural blebs may rupture, leading to fatal pneumothorax. The best hope for a major change in this dire picture is more effective programs aimed at prevention of smoking and other environmental exposures. Add emphysema. 50, 75, severe, early, late, scanty sputum, occasional, end stage, uncommon, end stage, normal or slightly increased, low, hyperinflation, normal heart size, pink puffer. Key concepts: chronic obstructive pulmonary disease. Most common in long-standing tobacco smokers, typically 40-pack years. Air pollutants also contribute. Underlying pulmonary pathology usually includes both chronic bronchitis and emphysema, often fatal due to development of heart failure or of respiratory failure due to superimposed infection. Emphysema in COP usually follows a centrosonar distribution characterized by permanent enlargement of air spaces distal to terminal bronchioles. Particularly severe in patients with alpha-1 antitrypsin deficiency, in which a panisonar pattern of emphysematic change may be seen. Tissue destruction is caused by elastasis and oxidants release from inflammatory cells, particularly neutrophils, which are responding to cellular injury caused by tobacco smoke and pollutants. Chronic bronchitis, defined as persistent productive cough for at least 3 consecutive months and at least 2 consecutive years. Dominant pathologic features are mucus hypersecretion due to enlargement of mucus-secreting glands and chronic inflammation associated with bronchiolar wall fibrosis. Predominant B. Chronic. Other forms of emphysema in addition to emphysema occurring in the setting of COP. Several other conditions may be associated with lung overinflation or focal emphysematic change and are mentioned here in brief. Compensatory hyperinflation. This term is used to designate dilation of alveoli in response to loss of lung substance elsewhere. For example, following surgical removal of a lung or lobe with cancer. Obstructive overinflation. In this condition, the lung expands because air is trapped within it. A common cause is subtotal obstruction of an airway by a tumor or foreign object. In infants, it may be caused by congenital lobar overinflation, which most often results from hypoplasia of bronchial cartilage. Overinflation occurs either 1 because of an obstruction that acts as ball valve, allowing air to enter on inspiration while preventing its exodus on expiration, or 2 because collaterals bring in air behind the obstruction. These collaterals consist of the pores of cone and other direct accessory bronchial-alveolar connections, the canals of Lambert. Obstructive overinflation can be life-threatening if the affected portion distends sufficiently to compress the adjacent uninvolved lung. Bullous emphysema. This is a descriptive term for large subpleural blebs or bully spaces greater than 1 cm in diameter in the distended state that can occur in any form of emphysema. Fig. 15.9, often near the apex. Rupture of the bully may give rise to pneumothorax. Interstitial emphysema. Entrance of air into the connective tissue stroma of the lung, mediastinum, or subcutaneous. Obstructive lung disease is 683, figure 15.9, bullous emphysema. Note the large subpleural bully upper left. Tissue produces interstitial emphysema. In most instances, it is caused by alveolar tears that occur in patients with pulmonary emphysema due to transient increases in intra-alveolar pressure, for example, during coughing. Less commonly, chest wounds or fractured ribs that puncture the lung provide the portal for entrance of air into surrounding soft tissues. Asthma. Asthma is a heterogeneous disease, usually characterized by chronic airway inflammation and variable expiratory airflow obstruction that produces symptoms such as wheezing, shortness of breath, chest tightness, and cough, which vary over time and in intensity. Symptomatic episodes are most likely to occur at night or in the early morning and are produced by bronchoconstriction that is at least partly reversible, either spontaneously or with treatment. Rarely, an unremitting attack called acute severe asthma, formerly known as status asthmaticus, may prove fatal. Usually, such patients have a long history of asthma. Between the attacks, patients may be virtually asymptomatic. Of note, there has been a significant increase in the incidence of asthma in the Western world over the past 40 to 50 years, a trend that has now started to abate. However, the prevalence of asthma continues to increase in lower-income countries and in some ethnic groups in which its prevalence was previously low. Asthma has several distinct clinical phenotypes, each with different underlying pathogenic mechanisms. It may be categorized as atopic evidence of allergen sensitization and immune activation, often in a patient with allergic rhinitis or eczema, or non-atopic, no evidence of allergen sensitization, of which several subtypes exist. In all types, episodes of bronchospasm may have diverse triggers, such as respiratory infections, especially viral infections, irritants, for example, smoke, fumes, cold air, stress, and exercise. One biologically meaningful and clinically useful way to classify asthma is based on its triggers. We will first briefly describe the various major subtypes of asthma, and then we'll delve more deeply into its pathogenesis. Atopic asthma. This type of asthma is a classic example of an IgE-mediated type, a hypersensitivity reaction discussed in Chapter 6. The disease usually begins in childhood and is triggered by environmental allergens, such as dust, pollens, cockroach or animal dander, and foods, which most frequently act in synergy with other pro-inflammatory environmental cofactors, most notably respiratory viral infections. A positive family history of asthma is common, and a skin test with the offending antigen in these patients results in an immediate wheal and flare reaction. Atopic asthma may also be diagnosed based on high total serum IgE levels or evidence of allergen sensitization by serum radioallergosorban test RAS, which can detect the presence of IgE antibodies that are specific for individual allergens. Non-atopic asthma. Individuals with non-atopic asthma do not have evidence of allergen sensitization, and skin test results are usually negative. A positive family history of asthma is less common in these patients. Respiratory infections due to viruses, for example, rhinovirus, parainfluenza virus, and respiratory syncytial virus are common triggers in non-atopic asthma. Inhaled air pollutants such as tobacco smoke, sulfur dioxide, ozone, and nitrogen dioxide may also contribute to the chronic airway inflammation and hyperactivity in some cases. As already mentioned, in some instances attacks may be triggered by seemingly innocuous events, such as exposure to cold and even exercise. Drug-induced asthma. Several pharmacologic agents provoke asthma. Aspirin-sensitive asthma is an uncommon type, occurring in individuals with recurrent rhinitis and nasal polyps. These individuals are exquisitely sensitive to small doses of aspirin as well as other non-steroidal anti-inflammatory medications, and they experience not only asthmatic attacks but also urticaria. Aspirin and related drugs trigger asthma in these patients by inhibiting the cyclooxygenase pathway of arachidonic acid metabolism, leading to a rapid decrease in prostaglandin A1. Normally, prostaglandin EPO inhibits enzymes that generate pro-inflammatory mediators such as leukotrienes B4, C4, D4, and EPHA, which are believed to have central roles in aspirin-induced asthma. Occupational asthma. This form of asthma may be triggered by fumes of epoxy resins, plastics, organic and chemical dust wood, cotton, platinum, gases toluene, or other chemicals, formaldehyde, penicillin products. Only minute quantities of chemicals are required to induce the attack, which usually occurs after repeated exposure. The 684 Chapter 15 The lung. Underlying mechanisms vary according to stimulus and include type I reactions, direct liberation of bronchoconstrictor substances, and hypersensitivity responses of unknown origin. Pathogenesis. Atopic asthma, the most common form of the disease, is caused by a THO-mediated IgE response to environmental allergens in genetically predisposed individuals. Airway inflammation is central to the disease pathophysiology and causes airway dysfunction partly through the release of potent inflammatory mediators and partly through remodeling of the airway wall. As the disease becomes more severe, there is increased local secretion of growth factors, which induce mucus gland enlargement, smooth muscle proliferation, angiogenesis, and fibrosis. Varying combinations of these processes help explain the different asthma subtypes, their response to treatment, and their natural history over a person's lifetime. The contributions of the immune response, genetics, and environment are discussed separately below, although they are closely intertwined. THO responses, IgE, and inflammation. Fundamental abnormality in asthma is an exaggerated THO response to normally harmless environmental antigens. Fig. 15. 10. THO cells secrete cytokines that promote inflammation and stimulate B cells to produce IgE and other antibodies. These cytokines include IL-4, which stimulates the production of IgE, IL-5, which activates locally recruited eosinophils, and IL-13, which stimulates mucus secretion from bronchial submucosal glands and also promotes IgE production by B cells. The T cells and epithelial cells secrete chemokines that recruit more T cells and eosinophils, thus exacerbating the reaction. As in other allergic reactions, Chapter 6, IgE binds to the Fc receptors on submucosal mast cells, and repeat exposure to the allergen triggers the mast cells to release granule contents and produce cytokines and other mediators, which collectively induce the early phase immediate hypersensitivity reaction and the late phase reaction. The early phase reaction is dominated by bronchoconstriction, increased mucus production, variable degrees of vasodilation, and increased vascular permeability. Bronchoconstriction is triggered by direct stimulation of subepithelial vagal parasympathetic receptors through both central and local reflexes triggered by mediators produced by mast cells and other cells in the reaction. The late phase reaction is dominated by recruitment of leukocytes, notably eosinophils, neutrophils, and more T cells. Although THO cells are the dominant T cell type involved in the disease, other T cells that contribute to the inflammation include Th17 IL-17 producing cells, which recruit neutrophils. Many mediators produced by leukocytes and epithelial cells have been implicated in the asthmatic response. The long list of suspects in acute asthma can be ranked based on the clinical efficacy of pharmacologic intervention with antagonists of specific mediators. Mediators whose role in bronchospasm is clearly supported by efficacy of pharmacologic intervention are 1 leukotrienes C4, D4, and EPHA, which cause prolonged bronchoconstriction as well as increased vascular permeability and increased mucus secretion. 2 acetylcholine, released from intrapulmonary parasympathetic nerves, which can cause airway smooth muscle constriction by directly stimulating muscarinic receptors. 3 IL-5, antagonists of which are effective in treating severe forms of asthma that are associated with peripheral blood eosinophilia. And 4 Galcan-10 GAL10, which is released from eosinophils and forms crystals known as Charcot-Leyden crystals. Long recognized as a feature of asthma, recent studies have shown that these crystals are strong inducers of inflammation and mucus production. A second group of agents are present at the scene of the crime but seem to have relatively minor contributions on the basis of lack of efficacy of potent antagonists or synthesis inhibitors. These include 1 histamine, a potent bronchoconstrictor, 2 prostaglandin D12, which elicits bronchoconstriction and vasodilation, and 3 platelet activating factor, which causes aggregation of platelets and release of serotonin from their granules. These mediators might yet prove important in certain types of chronic or non-allergic asthma. Finally, a large third group comprises suspects for whom specific antagonists or inhibitors are not available or have been insufficiently studied as yet. These include IL-4, IL-13, TNF, chemokines, for example, etaxin, also known as CC11, neuropeptides, nitric oxide, bradykinin, and endothelins. It is thus clear that multiple mediators contribute to the acute asthmatic response. Moreover, the composition of this mediator soup likely varies among individuals or different types of asthma. The appreciation of the importance of inflammatory cells and mediators in asthma has led to greater emphasis on anti-inflammatory drugs, such as corticosteroids, and its treatment. Genetic susceptibility. Susceptibility to atopic asthma is multigenic and often associated with increased incidence of other allergic disorders, such as allergic rhinitis, hay fever, and eczema. Genetic polymorphisms linked to asthma and other allergic disorders were described in Chapter 6. Suffice it to say here that many of these are likely to influence immune responses and the subsequent inflammatory reaction. Some of the stronger or more interesting genetic variants associated with asthma include the following. The susceptibility locus for asthma located on chromosome 5 near the gene cluster encoding the cytokines IL-3, IL-4, IL-5, IL-9, and IL-13 and the IL-4 receptor. Among the genes in this cluster, polymorphisms in the IL-13 gene have the strongest and most consistent associations with asthma or allergic disease, while IL-4 receptor gene variants are associated with atopy, elevated total serum IgE, and asthma. Particular class Roman II HLA alleles linked to production of IgE antibodies against some antigens, such as ragweed pollen. Variants associated with the genes encoding IL-33, a member of the IL-1 family of cytokines, and its receptor, ST12, which induce the production of THO cytokines. Variants associated with the gene encoding thymic stromal lymphopoietin TSLP, a cytokine produced by epithelium that may have a role in initiating allergic reactions. Obstructive lung disease is 685. A normal airway C triggering of asthma. Epithelium, basement membrane, lamina propria, smooth muscle, glands, cartilage, mucous goblet cell. IgE B cell, IgE antibody, B, TH1 cell, IL4, TH1, IL5, T cell receptor pollen, antigen allergen, dendritic, cell, IgE FC receptor, IL5, ETEX and mucous aligning, mast cell. Eosinophil recruitment, activation, release of granules and mediators, goblet cell, the airway in asthma, mucous goblet cell, mucosal lining antigen mucus. Eosinophil, basement membrane, macrophage, smooth muscle, glands, mast cell. Eosinophil, lymphocyte, neutrophil, vagal afferent nerve, eosinophil, vagal afferent nerve. Increased vascular permeability and edema, mast cell, TH1 smooth muscle, major basic protein, eosinophil, cationic protein, basophil, eosinophil, neutrophil, TH1. E immediate phase minutes, E late phase hours. Figure 15.10 and B comparison of a normal airway and an airway involved by asthma. The asthmatic airway is marked by accumulation of mucus in the bronchial lumen secondary to an increase in the number of mucus-secreting goblet cells in the mucosa and hypertrophy of submucosal glands. Intense chronic inflammation due to recruitment of eosinophils, macrophages, and other inflammatory cells. Thickened basement membrane, and hypertrophy and hyperplasia of smooth muscle cells. D. Inhaled allergens. Antigen elicit a TH1-dominated response favoring IgE production and eosinophil recruitment. D. On re-exposure to antigen. The immediate reaction is triggered by antigen-induced cross-linking of IgE-bound to Fc receptors on mast cells. These cells release perform mediators that directly and via neuronal reflexes induce bronchospasm, increase vascular permeability, mucus production, and recruitment of leukocytes. Leukocytes recruited to the site of reaction neutrophils, eosinophils, and basophils. Lymphocytes and monocytes release additional mediators that initiate the late-phase reaction. Several factors released from eosinophils, for example, major basic protein, eosinophil cationic protein, also cause damage to the epithelium. IL-5, interleukin 5. Chapter 15. The lung, morphology. Figure 15.11 bronchus from an asthmatic patient showing goblet cell hyperplasia, green arrow, sub, basement membrane fibrosis, black arrow, eosinophilic inflammation, yellow arrow, and muscle hypertrophy, blue arrow. Environmental factors. Asthma is a disease of industrialized societies where the majority of people live in cities. Two ideas, neither wholly satisfying, have been proposed to explain this association. First, industrialized environments contain many airborne pollutants that can serve as allergens to initiate the TH1 response. Second, city life tends to limit the exposure of very young children to certain antigens, particularly microbial antigens, and exposure to such antigens may protect children from asthma and atopy. The idea that microbial exposure during early life reduces the later incidence of allergic and some autoimmune diseases has been popularized as the hygiene hypothesis. Although the underlying mechanisms of this protective effect are unclear, it has spurred trials of probiotics and intentional early exposure of children to putative allergens to decrease their risk of later developing allergies. Infections do not cause asthma by themselves, but may be important cofactors. Young children with aeroallergen sensitization who develop lower respiratory tract viral infections, rhinovirus type C, respiratory syncytial virus, have a 10 to 30-fold increased risk of developing persistent and / or severe asthma. Both viral and bacterial infections identified by cultures and non-culture tools are associated with acute exacerbations of the disease. Over time, repeated bouts of allergen exposure and immune reactions result in structural changes in the bronchial wall, referred to as airway remodeling. These changes, described later in greater detail, include hypertrophy and hyperplasia of bronchial smooth muscle, epithelial injury, increased airway vascularity, subepithelial mucus gland enlargement, and subepithelial fibrosis. A small subset of patients with asthma, many of whom have severe disease that is refractory to glucocorticoids, as inflammatory infiltrates that are enriched for neutrophils rather than eosinophils. This form of the disease may be driven by a Th17 T cell response to chronic bacterial colonization of the lung. In patients dying of acute severe asthma status asthmaticus, the lungs are overinflated and contain small areas of agliotosis. The most striking gross finding is occlusion of bronchi and bronchioles by thick, tenacious mucus plugs, which often contain shed epithelium. A characteristic finding in sputum or bronchoalveolar lavage specimens of patients with atopic asthma is Kirschmann's spirals, which may result from extrusion of mucus plugs from subepithelial mucus gland ducts or bronchioles. Also present are numerous eosinophils and Charcot-Leyden crystals composed of the eosinophil-derived protein galectin-10. The other characteristic histologic findings of asthma, collectively called airway remodeling figs, 15, 10b and 15, 11, include thickening of airway wall, basement membrane fibrosis due to deposition of type I and Roman III collagens, increased vascularity, increase in the size of the submucosal glands and number of airway goblet cells, hypertrophy and / or hyperplasia of the bronchial wall muscle, with increased extracellular matrix, while acute airflow obstruction is primarily attributed to muscular bronchoconstriction, acute edema, and mucus plugging. Airway remodeling may contribute to chronic irreversible airway obstruction. 686. Clinical features. A classic acute asthmatic attack lasts up to several hours. In some patients, however, the cardinal symptoms of chest tightness, dyspnea, wheezing, and coughing with or without sputum production are present at a low level constantly. In its most severe form, acute severe asthma, the paroxysm persists for days or even weeks, sometimes causing airflow obstruction that is so extreme that marked cyanosis or even death ensues. The diagnosis is based on demonstration of an increase in airflow obstruction from baseline levels, difficulty with exhalation, prolonged expiration, wheeze, and in those with atopic asthma, identification of eosinophilia in the peripheral blood and eosinophils, Kirschmann's spirals, and Charcot-Leyden crystals in the sputum. In the usual case with intervals of freedom from respiratory difficulty, the disease is more discouraging and disabling than lethal, and most individuals are able to maintain a productive life. Therapy is based on the severity of the disease. The centerpieces of standard therapy are bronchodilators, glucocorticoids, and leukotriene antagonists. For severe and difficult-to-treat asthma in adolescents and adults, novel biologic therapies targeting inflammatory mediators such as IL-5 blocking antibodies, which is effective in severe asthma associated with THO immune responses and peripheral blood eosinophilia, are now available. Up to 50% of childhood asthma remits in adolescents only to return in adulthood in a significant number of patients. In other cases, there is a variable decline in baseline lung function over time. Obstructive lung disease is 687. Key concepts. Asthma. Asthma is characterized by reversible bronchoconstriction caused by airway hyperresponsiveness to a variety of stimuli. Atopic asthma is caused by THO and 8E-mediated immunologic reaction to environmental allergens and is characterized by acute phase, immediate, and late phase reactions. The THO, cytokines IL-4, IL-5, and IL-13 are important mediators. Triggers for non-atopic asthma are less clear but include viral infections and inhaled air pollutants, which can also trigger atopic asthma. Eosinophils are key inflammatory cells in atopic asthma. Other inflammatory cells implicated in its pathogenesis include mast cells, neutrophils, and T lymphocytes. Airway remodeling basement membrane fibrosis, hypertrophy of bronchial glands, and smooth muscle hyperplasia as an irreversible component to the obstructive disease. Bronchitis. Bronchitis is a disorder in which destruction of smooth muscle and elastic tissue by inflammation stemming from persistent or severe infections leads to permanent dilation of bronchi and bronchioles. Because of better control of lung infections, bronchitis is now uncommon, but may still develop in association with the following: congenital or hereditary conditions that predispose to chronic infections, including cystic fibrosis, intralobar sequestration of the lung, immunodeficiency states, primary ciliary dyskinesia, and Cardiac syndrome. Severe necrotizing pneumonia caused by bacteria, viruses, or fungi. This may be a single severe episode or recurrent infections. Bronchial obstruction, due to tumor, foreign body, or mucus impaction. In each instance, the bronchitis is localized to the obstructed lung segment. Immune disorders, including rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, and the post-transplant setting chronic rejection after lung transplant and chronic graft versus host disease after hematopoietic stem cell transplantation. Up to 50% of cases are idiopathic, lacking the aforementioned associations, in which there appears to be dysfunctional host immunity to infectious agents leading to chronic inflammation. Pathogenesis, obstruction, and infection are the major conditions associated with bronchitis. The infections that lead to bronchitis are usually the result of a defect in airway clearance. Sometimes this defect stems from airway obstruction, leading to distal pooling of secretions. Both mechanisms are readily apparent in a severe form of bronchitis that is associated with cystic fibrosis, Chapter 10. In cystic fibrosis, the primary defect in ion transport results in thick viscous secretions that perturb mucociliary clearance and lead to airway obstruction. This sets the stage for chronic bacterial infections, which cause widespread damage to airway walls. With destruction of supporting smooth muscle and elastic tissue, the bronchi become markedly dilated, while smaller bronchioles are progressively obliterated as a result of fibrosis bronchiolitis obliterans. Primary ciliary dyskinesia is an autosomal recessive disease with a frequency of 1 in 10,000 to 20,000 births. The disease-causing mutations result in ciliary dysfunction due to defects in ciliary motor proteins, for example, mutations involving dynein, again preventing mucociliary clearance, setting the stage for recurrent infections that lead to bronchitis. Ciliary function also is necessary during embryogenesis to ensure proper rotation of the developing organs in the chest and abdomen. In its absence, their location becomes a matter of chance. As a result, approximately half of patients with primary ciliary dyskinesia have Cardiac syndrome, marked by situs inversus or a partial lateralizing abnormality associated with bronchitis and sinusitis. Males with this condition also tend to be infertile as a result of sperm dysmotility. Allergic bronchopulmonary aspergillosis occurs in patients with asthma or cystic fibrosis and frequently leads to the development of bronchitis. It is a hyperimmune response to the fungus Aspergillus fumigatus. Sensitization to Aspergillus leads to activation of THO helper T cells, which release cytokines that recruit eosinophils and other leukocytes. Characteristically, there are high serum IgE levels, serum antibodies to Aspergillus, intense airway inflammation with eosinophils, and formation of mucus plugs, which play a primary role in the development of bronchitis. Morphology: bronchitis usually affects the lower lobes bilaterally, particularly air passages that are vertical, and is most severe in the more distal bronchi and bronchioles. When tumor or aspiration of foreign bodies leads to bronchitis, the involvement is localized. The airways are dilated, sometimes up to 4 times normal size. Characteristically, the bronchi and bronchioles are so dilated that they can be followed almost to the pleural surfaces. By contrast, in the normal lung, the bronchioles cannot be followed by IB on a 0.2 to 3 cm from the pleural surfaces. On the cut surface of the lung, the dilated bronchi appear cystic and are filled with mucopurulent secretions. Fig. 15, 12. The histologic findings vary with activity and chronicity of the disease. In the full-blown, active case, there is an intense, acute, and chronic inflammatory exudation within the walls of the bronchi and bronchioles, associated with desquamation of the lining epithelium and extensive ulceration. There also may be squamous metaplasia of the remaining epithelium in response to chronic inflammation, further diminishing mucociliary clearance. In some instances, necrosis destroys the bronchial or bronchiolar walls and forms a lung abscess. Fibrosis of the bronchial and bronchiolar walls and parabronchiolar fibrosis develop in more chronic cases, leading to varying degrees of subtotal or total obliteration of bronchiolar lumens. Haemophilus influenzae is found in approximately half in Pseudomonas aeruginosa in 12% to 30% of sputum cultures from patients with bronchitis with 4 other types of bacteria. 688 Chapter 15 The lung. Chronic diffuse interstitial restrictive diseases. Figure 15.12 bronchiectasis in a patient with cystic fibrosis who underwent lung transplantation. Cut surface of lung shows markedly distended peripheral bronchi filled with mucopurulent secretions, including non-tuberculous mycobacteria, making up most of the remaining cases in patients from different geographic locations. This observation suggests that the inflamed, mucoid, sometimes anaerobic, bronchiectatic microenvironment favors colonization by relatively few microbial species. In allergic bronchopulmonary aspergillosis, fungal hyphae can be seen on special stains within the mucoinflammatory contents of the dilated segmental bronchi. In late stages, the fungus may infiltrate the bronchial wall. Major clinical features: bronchiectasis causes severe, persistent cough, expectoration of foul smelling, sometimes bloody sputum, dyspnea and orthopnea in severe cases, and, on occasion, hemoptysis, which may be massive. Symptoms are often episodic and are precipitated by upper respiratory tract infections or the introduction of new pathogenic agents. Paroxysms of cough are particularly frequent when the patient rises in the morning, as the change in position causes collections of pus and secretions to drain into the bronchi. Obstructive respiratory insufficiency can lead to marked dyspnea and cyanosis. However, current treatments with better antibiotics and physical therapy have improved outcomes considerably, and life expectancy has almost doubled. Hence, core pulmonale, brain abscesses, and amyloidosis are less frequent complications of bronchiectasis currently than in the past. Restrictive lung disorders fall into two general categories: one, chronic interstitial and infiltrative diseases, such as pneumoconiosis and interstitial fibrosis of unknown etiology, and two, chest wall disorders, for example, neuromuscular diseases such as poliomyelitis, severe obesity, pleural diseases, and kyphoscoliosis, which are not discussed here. Chronic interstitial pulmonary diseases are a heterogeneous group of disorders characterized predominantly by inflammation and fibrosis of the lung interstitium associated with pulmonary function studies indicative of restrictive lung disease. Diffuse restrictive diseases are categorized based on histology and clinical features. Table 15.5. Many of the entities are of unknown cause and pathogenesis, and some have an intra-alveolar as well as an interstitial component. Patients have dyspnea, tachypnea, and inspiratory crackles, and eventual cyanosis, without wheezing or other evidence of airway obstruction. The classic functional abnormalities are reductions in diffusion capacity, lung volume, and lung compliance. Chest radiographs show bilateral lesions that take the form of small nodules, irregular lines, or ground glass shadows, all corresponding to areas of interstitial fibrosis. Although the entities can often be distinguished in their early stages, advanced forms are hard to differentiate because all result in diffuse scarring of the lung, often referred to as end-stage lung or honeycomb lung. Eventually, secondary pulmonary hypertension and right-sided heart failure core pulmonale may result. Fibrosing diseases. Idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis IPF refers to a clinical pathologic syndrome marked by progressive interstitial pulmonary fibrosis and respiratory failure. In Europe, the categories of C5 lung chronic interstitial fibrillary TT disease. Fibrosing. Usual interstitial pneumonia. Idiopathic pulmonary fibrosis. Non-specific interstitial pneumonia. Cryptogenic organizing pneumonia. Connective tissue disease. Associated pneumoconiosis. Drug reactions. Radiation pneumonitis. Granulomatous. Sarcoidosis. Hypersensitivity pneumonitis. Eosinophilic. Smoking related. Desquamative interstitial pneumonia. Respiratory bronchiolitis. Associated interstitial lung disease. Other Langerhans cell histiocytosis. Pulmonary alveolar proteinosis. Lymphoid interstitial pneumonia. BL. Chronic diffuse interstitial restrictive diseases. 689. The term cryptogenic fibrosing alveolitis is more popular. IPF has characteristic radiologic, pathologic, and clinical features. The histologic pattern of fibrosis is referred to as usual interstitial pneumonia UIP, which can often be diagnosed based on its characteristic appearance on computed tomography scans. The UIP pattern can also be seen in other diseases, notably connective tissue diseases, chronic hypersensitivity pneumonia, and asbestosis. These must be distinguished from IPF based on other clinical, laboratory, and histologic features. Pathogenesis. While the cause of IPF remains unknown, it appears that it arises in genetically predisposed individuals who are prone to aberrant repair of recurrent alveolar epithelial cell injuries caused by environmental exposures. Fig. 15.13. The implicated factors are as follows. Environmental factors. Most important among these is cigarette smoking, which increases the risk of IPF severalfold. IPF incidence is also increased in individuals who are exposed to air pollution, microaspiration, metal fumes, and wood dust, or who work in certain occupations, including farming, hairdressing, and stone polishing. It is hypothesized that exposure to environmental irritants, environmental factors, smoking, occupational exposure, other irritants, toxins, viral infection, the risk epithelium, age, genetics, telomerase mutations, surfactant mutations, MUC5B variant, persistent epithelial injury/activation, innate and adaptive immune response, pro-fibrogenic factors, abnormal intracellular signaling, proliferation, collagen production, or toxins in each of these contexts causes recurrent alveolar epithelial cell damage. Genetic factors. The vast majority of individuals who smoke or who have other environmental exposures linked to IPF do not develop the disorder, indicating that additional factors are required for its development. Mutations in the TERT, CARN, and RT-lone genes, all of which are involved with the maintenance of telomeres, are associated with increased risk of IPF. You will recall that maintenance of telomeres, the ends of chromosomes, is necessary to prevent cellular senescence. Up to 15% of familial IPF is associated with inherited defects in genes that maintain telomeres, while up to 25% of sporadic IPF cases are associated with abnormal telomere shortening in peripheral blood lymphocytes, a finding that also points to a problem with telomere maintenance. Other, rare familial forms of IPF are associated with mutations in genes encoding components of surfactant. These mutations create folding defects in the affected proteins, leading to activation of the unfolded protein response in type Roman II pneumocytes. This in turn appears to make pneumocytes more sensitive to environmental insults, leading to cellular dysfunction and injury. Finally, Roughly one-third of IPF cases are associated with a single nucleotide polymorphism in the promoter of the MUC5B gene that greatly increases the secretion of MUC5B, a member of the mucin family. This may in turn alter mucociliary clearance, but precisely how this alteration relates to IPF risk is uncertain. Age. IPF is a disease of older individuals, rarely appearing before the age of 50 years. Whether this association stems from aging-related telomere shortening or from other acquired changes associated with aging is unknown. It is easy to imagine how some of the factors cited herein might combine to exacerbate alveolar epithelial cell damage and senescence, which seems to be the initiating event in IPF. But it must be admitted that the pathogenesis of IPF is complex and poorly understood. For example, it is unknown precisely how alveolar epithelial cell damage translates into interstitial fibrosis. One model holds that the injured epithelial cells are the source of profibrogenic factors such as TGF-beta, whereas a second, mutually exclusive model proposes that innate and adaptive immune cells produce such factors as part of the host response to epithelial cell damage. Other work has described abnormalities in the fibroblasts themselves that involve changes in intracellular signaling and features reminiscent of epithelial mesenchymal transition chapter 7, but a causal link between these alterations and fibrosis has not been established. Fibrosis morphology. Figure 15.13 proposed pathogenic mechanisms in idiopathic pulmonary fibrosis. Environmental factors that are potentially injurious to alveolar epithelium interact with genetic or aging-related factors that place epithelium at risk, creating a persistent epithelial injury. Factors secreted from injured/activated epithelium, possibly augmented by factors released from innate and adaptive immune cells responding to danger signals produced by damaged epithelium, activate interstitial fibroblasts. There is some evidence that these activated fibroblasts exhibit signaling abnormalities that lead to increased signaling through the PI3K/AKT pathway. The activated fibroblasts synthesize and deposit collagen, leading to interstitial fibrosis and eventual respiratory failure. Grossly, the pleural surfaces of the lung are cobblestone as a result of the retraction of scars along the interlobular septum. The cut surface shows firm, rubbery white areas of fibrosis, which occurs preferentially in the lower lobes, the subpleural regions, and along the interlobular septum. Microscopically, the hallmark is patchy interstitial fibrosis, which varies in intensity, Fig. 15-14, and age. The earliest lesions contain an exuberant proliferation of fibroblasts, fibroblastic foci. With time, these areas become more fibrotic and less cellular. Quite typical is the 690 chapter 15, the lung. Survival is about 3.8 years after diagnosis. Lung transplantation is the only definitive therapy. However, two drugs, a tyrosine kinase inhibitor and a TGF-beta antagonist, have both been shown to slow disease progression and represent the first effective, albeit modestly so, targeted therapies for IPF. Nonspecific interstitial pneumonia. Despite its nonspecific name, this entity is important to recognize, since these patients have a much better prognosis than patients with UIP. Nonspecific interstitial pneumonia is most often associated with connective tissue disease but may also be idiopathic. Morphology. Figure 15.14 Usual interstitial pneumonia. Fibrosis is more pronounced in the subpleural region. Courtesy Dr. Nicole Cipriani, Department of Pathology, University of Chicago, Ill. Coexistence of both early and late lesions. Fig. 15. The dense fibrosis causes the destruction of alveolar architecture and the formation of cystic spaces lined by hypoplastic type Roman II pneumocytes or bronchiolar epithelium honeycomb fibrosis. With adequate sampling, these diagnostic histologic changes, i.e., areas of dense fibrosis and fibroblastic foci, can be identified even in advanced IPF. There is mild to moderate inflammation within the fibrotic areas, consisting of mostly lymphocytes admixed with a few plasma cells, neutrophils, eosinophils, and mast cells. Foci of squamous metaplasia and smooth muscle hyperplasia may be present, along with pulmonary arterial hypertensive changes, intimal fibrosis, and medial thickening. In acute exacerbations, DAD may be superimposed on these chronic changes. Clinical features. IPF begins insidiously with gradually increasing dyspnea on exertion and dry cough. Most patients are 55 to 75 years old at presentation. Hypoxemia, cyanosis, and clubbing occur late in the course. The course in individual patients is unpredictable. Usually there is slowly progressive respiratory failure, but some patients have acute exacerbations and follow a rapid downhill clinical course. The median. Figure 15.15 Usual interstitial pneumonia. Fibroblastic focus with fibers running parallel to surface and bluish myxoid extracellular matrix. Honeycombing is present on the left. On the basis of its histology, nonspecific interstitial pneumonia is divided into cellular and fibrosing patterns. The cellular pattern consists primarily of mild to moderate chronic interstitial inflammation, containing lymphocytes and a few plasma cells, and a uniform or patchy distribution. The fibrosing pattern consists of diffuse or patchy interstitial fibrotic lesions of roughly the same stage of development, an important distinction from UIP. Fibroblastic foci, honeycombing, hyaline membranes, and granulomas are absent. Clinical features. Patients present with dyspnea and cough of several months' duration. They are more likely to be female non-smokers in their sixth decade of life. On imaging, the lesions have the appearance of bilateral, symmetric, predominantly lower lobe reticular opacities. Patients having the cellular pattern are somewhat younger than those with the fibrosing pattern and have a better prognosis. Cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia is most often seen as a response to infection or inflammatory injury of the lungs. It has been associated with viral and bacterial pneumonias, inhaled toxins, drugs, connective tissue disease, and graft versus host disease in hematopoietic stem cell transplant recipients. Patients present with cough and dyspnea and have patchy subpleural or parabronchial areas of airspace consolidation radiographically. Histologically, it is characterized by the presence of polypoid plugs of loose organizing connective tissue mass and bodies within alveolar ducts, alveoli, and often bronchioles. Fig. 15.16. The connective tissue is all of the same age, and the underlying lung architecture is normal. There is no interstitial fibrosis or honeycomb lung. Some patients recover spontaneously, but most need treatment with oral steroids for 6 months or longer for complete recovery. The long-term prognosis is dependent on the underlying disorder. Pulmonary involvement in autoimmune diseases. Many autoimmune diseases, also referred to as connective tissue diseases because of their frequent association with arthritis, can involve the lung at some point in their course. Those that are well recognized for producing pulmonary disease include systemic lupus erythematosus, rheumatoid arthritis, progressive systemic sclerosis scleroderma, and dermatomyositis polymyositis. Pulmonary involvement can take different histologic patterns, not specific interstitial. Chronic diffuse interstitial restrictive disease is 691, a B figure 15.16 cryptogenic organizing pneumonia. Some alveolar spaces are filled with balls of fibroblasts mass in bodies, while the alveolar walls are relatively normal, a low power, B high power. Pneumonia, usual interstitial pneumonia, organizing pneumonia, and bronchiolitis are the most common. Rheumatoid arthritis is associated with pulmonary involvement in 30% to 40% of patients as 1 chronic pleuritis, with or without effusion, 2 diffuse interstitial pneumonitis and fibrosis, 3 intrapulmonary rheumatoid nodules, 4 follicular bronchiolitis, or 5 pulmonary hypertension. When lung disease occurs in the setting of rheumatoid arthritis and a pneumoconiosis described next, it is referred to as Kaplan syndrome. Systemic sclerosis scleroderma is associated with diffuse interstitial fibrosis, not specific interstitial pattern, more common than usual interstitial pattern and pleural involvement. Lupus erythematosus may cause patchy, transient parenchymal infiltrates or occasionally severe lupus pneumonitis, as well as pleuritis and pleural effusions. Pulmonary involvement in these diseases has a variable prognosis that is determined by the extent and histologic pattern of involvement. Key concepts: chronic interstitial lung diseases. Diffuse interstitial fibrosis of the lung gives rise to restrictive lung diseases characterized by reduced lung compliance and reduced FVC. The ratio of FeV1 to FVC is normal. Idiopathic pulmonary fibrosis is prototypic of restrictive lung diseases. It is characterized by patchy interstitial fibrosis, fibroblastic foci, inflammation of cystic spaces, honeycomb lung. This histologic pattern is known as usual interstitial fibrosis. The cause of idiopathic pulmonary fibrosis is unknown, but genetic analyses point to roles for senescence of alveolar epi. Ileum due to telomere shortening, altered mucin production, and abnormal signaling in alveolar fibroblasts. Injury to alveolar epithelial cells sets in motion events that lead to increased local production of fibrogenic cytokines, such as TGF-beta. Pneumoconiosis. The term pneumoconiosis, originally coined to describe the non-neoplastic lung reaction to inhalation of mineral dust encountered in the workplace, now also includes disease induced by chemical fumes and vapors. Simplified classification is presented in Table 15.6. Where implemented, regulations limiting worker exposure have resulted in a marked decrease in dust-associated diseases. Pathogenesis-specific factors that influence the development of dust-borne pneumoconiosis include the following: dust retention, which is determined by the dust concentration in ambient air, the duration of exposure, and the effectiveness of clearance mechanisms. Any influence, such as cigarette smoking, that impairs mucociliary clearance significantly increases the accumulation of dust in the lungs. Particle size. Most dangerous particles are from 1 to 5 μm in diameter because particles of this size can reach the terminal small airways and air sacs and deposit in their linings. Particle solubility and cytotoxicity, which are influenced by particle size. In general, small particles composed of injurious substances of high solubility are more likely to produce rapid onset acute lung injury. By contrast, larger particles are more likely to resist dissolution and may persist within the lung parenchyma for years. These tend to evoke fibrous and collagenous pneumoconiosis, such as is characteristic of silicosis. Particle uptake by epithelial cells will egress across epithelial linings, which allows direct interactions with fibroblasts and interstitial macrophages to occur. Some particles may reach the lymph nodes through lymphatic drainage directly or within migrating macrophages and thereby initiate an adaptive immune response to components of the particulates or to self-proteins modified by the particles or both. Activation of the inflammasome chapter 3, which occurs following the phagocytosis of certain particles by macrophages. This innate immune response amplifies the intensity and the duration of the local reaction. Tobacco smoking, which worsens the effects of all inhaled mineral dust, but particularly those caused by asbestos. 692 Chapter 15 The lung. Table 15.6 Lung diseases caused by air pollutants. Agent disease, mineral dust, coal dust anthracosis, macules progressive massive fibrosis Kaplan syndrome, silica silicosis Kaplan syndrome, asbestos asbestosis pleural plaques Kaplan syndrome, mesothelioma carcinoma of the lung, larynx, stomach, colon. Beryllium acute borreliosis, beryllium granulomatosis, lung carcinoma, iron oxide siderosis, barium sulfate baritosis, tin oxide stenosis, organic dust that induce hypersensitivity pneumonitis. Moldy hay farmer's lung, Bagus bagasosis, bird droppings bird breeder's lung, organic dust that induce asthma, cotton, flax, hemp bisonosis, red cedar dust asthma. Chemical fumes and vapors, nitrous oxide, sulfur dioxide, ammonia, bronchitis, asthma benzene, insecticides pulmonary edema, ARDS mucosal injury fulminant poisoning. ARDS, acute respiratory distress syndrome, exposure, coal mining particularly hard coal, metal casting work, sandblasting, hard rock mining, stone cutting, others. Mining, milling, manufacturing, and installation and removal of insulation, mining, manufacturing, welding, mining, farming, manufacturing, wallboard, paper, bird handling, textile manufacturing, lumbering, carpentry, occupational and accidental exposure, morphology. In general, only a small percentage of exposed people develop occupational respiratory diseases, implying a genetic predisposition to their development. Many of the diseases listed in Table 15.6 are quite uncommon, hence only a select few that cause pulmonary fibrosis are presented next. Carbon deposits are dark black in color and are readily visible grossly and microscopically. Anthracosis is the most innocuous. Coal-induced pulmonary lesion in coal miners and is also seen to some degree in urban dwellers and tobacco smokers. Inhale. Carbon pigment is engulfed by alveolar or interstitial macrophages, which accumulate in the connective tissue adjacent to the lymphatics and in organized lymphoid tissue adjacent to the bronchi or in the lung hills. Simple cold workers pneumoconiosis is characterized by cold macules 1 to 2 mm in diameter and somewhat larger cold nodules. Cold macules consist of carbon-laden macrophages. Nodules also contain a delicate network of collagen fibers. Although these lesions are scattered throughout the lung, the upper lobes and upper zones of the lower lobes are more heavily involved. They are located primarily adjacent to respiratory bronchioles, the site of initial dust accumulation. In due course, dilation of adjacent alveoli occurs, sometimes giving rise to central-lobular emphysema. Complicated cold workers pneumoconiosis progressive. Massive fibrosis occurs on a background of simple disease and generally requires many years to develop. It is characterized by cold workers pneumoconiosis. Cold workers pneumoconiosis is lung disease caused by inhalation of cold particles and other admixed forms of dust. Dust reduction measures in coal mines around the globe have drastically reduced its incidence. The spectrum of lung findings in cold workers is wide, varying from asymptomatic anthracosis to simple cold workers pneumoconiosis with little to no pulmonary dysfunction, to complicated cold workers pneumoconiosis or progressive massive fibrosis, in which lung function is compromised. Contaminating silica in the coal dust favors the development of progressive disease. In most cases, carbon dust itself is the major culprit, and studies have shown that complicated lesions contain much more dust than simple lesions. Cold workers may also develop emphysema and chronic bronchitis independent of smoking. Chronic diffuse interstitial restrictive disease is 693. Figure 15.17 progressive massive fibrosis in a cold worker. A large amount of black pigment is associated with dense interstitial fibrosis. From Clatty C. Robbins and Cotran Atlas of Pathology, It2, Philadelphia, 2010, Saunders, P121. Intensely blackened scars 1 cm or larger, sometimes up to 10 cm in greatest diameter. They are usually multiple. Microscopically, the lesions consist of dense collagen and pigment. Fig. 15, 17. The center of the lesion is often necrotic, most likely due to local ischemia. African Americans are at higher risk than Caucasians. As shown in Table 15.6, workers in a large number of occupations are at risk, including individuals involved with the repair, rehabilitation, or demolition of concrete structures such as buildings and roads. The disease also occurs in workers producing stressed denim by sandblasting, stone carvers, and jewelers using chalk molds. Occasionally, heavy exposure over months to a few years can result in acute silicosis, a disorder characterized by the accumulation of abundant lipoproteinaceous material within alveoli identical morphologically to alveolar proteinosis. Discussed later. Pathogenesis. Phagocytosis of inhaled silica crystals by macrophages activates the inflammasome and stimulates the release of inflammatory mediators, particularly IL-1 and IL-18. This in turn leads to the recruitment of additional inflammatory cells and activates interstitial fibroblasts, leading to collagen deposition. Silica occurs in both crystalline and amorphous forms, but crystalline forms including quartz, cristobalite, and tridymite are much more fibrogenic. Of these, quartz is most commonly implicated. The lack of severe responses to silica in coal and hematite miners is thought to be due to coating of silica with other minerals, especially clay components, which render the silica less toxic. Although amorphous silicates are biologically less active than crystalline silica, heavy lung burdens of these minerals may also produce lesions. Morphology. Silicosis is characterized grossly in its early stages by tiny, barely palpable, discrete pale to black, and if coal dust is also present, nodules in the hilar lymph nodes and upper zones of the lungs. As the disease progresses, these nodules coalesce into hard, collagenous scars. Fig. 15, 18. Some nodules may undergo central. Clinical features. Cold workers pneumoconiosis is usually benign, causing little decrement in lung function. Even mild forms of complicated cold workers pneumoconiosis do not affect lung function significantly. In a minority of cases, fewer than 10%, progressive massive fibrosis develops, leading to increasing pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Once progressive massive fibrosis develops, it may continue to worsen even if further exposure to dust is prevented. Unlike silicosis discussed next, there is no convincing evidence that cold workers pneumoconiosis increases susceptibility to tuberculosis, nor does it predispose to cancer in the absence of smoking. However, domestic indoor use of smoky coal bitumen for cooking and heating, a common practice in lower income parts of the world, is associated with an increased risk of lung cancer death, even in those who do not smoke. Silicosis. Silicosis is a common lung disease caused by inhalation of pro-inflammatory crystalline silicon dioxide silica. It usually presents after decades of exposure as slowly progressing, nodular, fibrosing pneumoconiosis. Currently, silicosis is the most prevalent chronic occupational disease in the world. Both dose and race are important in developing silicosis. Figure 15.18 Advanced silicosis. Scarring has contracted the upper lobe into a small dark mass arrow. Note the dense pleural thickening. Courtesy Dr. John Godowski, Brigham and Women's Hospital, Boston, Mass. Chapter 15 The lung. Figure 15.19 Several coalescent collagenous silicotic nodules. Courtesy Dr. John Godowski, Brigham and Women's Hospital, Boston, Mass. Softening and cavitation due to superimposed tuberculosis or to ischemia. Fibrotic lesions may also occur in the hilar lymph nodes and pleura. Sometimes, thin sheets of calcification occur in the lymph nodes and are seen radiographically as extra calcification, i.e., calcium surrounding a zone lacking calcification. If the disease continues to progress, expansion and coalescence of lesions may produce progressive massive fibrosis. Histologic examination reveals the hallmark lesion characterized by a central area of or collagen fibers with a more peripheral zone of dust laden. Macrophages. Fig. 15, 19. Examination of the nodules by polarized microscopy reveals weakly birefringent silicate particles. 694. Clinical features. The onset of silicosis may be slow and insidious 10 to 30 years after exposure. This is most common, accelerated within 10 years of exposure, or rapid weeks or months after intense exposure to fine dust high in silica. This is rare. Chest radiographs typically show a fine nodularity in the upper zones of the lung. Pulmonary function is either normal or only moderately affected early in the course, and most patients do not develop shortness of breath until progressive massive fibrosis supervenes. The disease may continue to worsen even if the patient is no longer exposed. It is slow to kill, but impaired pulmonary function may severely limit activity. Silicosis also is associated with an increased susceptibility to tuberculosis and a twofold increased risk of lung cancer. The former may be because crystalline silica inhibits the ability of pulmonary macrophages to kill phagocytosed mycobacteria. The link to cancer is not fully understood, but it is but one of many chronic inflammatory conditions that increase the risk of carcinoma in involved tissues. Chapter 7. Asbestos-related diseases. Asbestos is a family of pro-inflammatory crystalline hydrated silicates that are associated with pulmonary fibrosis and various forms of cancer. Use of asbestos is tightly restricted in many higher-income countries. However, there is little, if any, control in lower-income parts of the world. Asbestos-related diseases include localized fibrous plaques or, rarely, diffuse pleural fibrosis, pleural effusions, recurrent, parenchymal interstitial fibrosis, asbestosis, lung carcinoma, mesothelioma, laryngeal, ovarian, and perhaps other extrapulmonary neoplasms, including colon carcinoma. Increased risks for systemic autoimmune diseases and cardiovascular disease also have been proposed. The increased incidence of asbestos-related cancers in family members of asbestos workers has alerted the general public to the potential hazards of even low-level exposure to asbestos. However, the necessity of expensive asbestos abatement programs for environments such as schools with low, but measurable, airborne asbestos fiber counts remains a matter of contention. Pathogenesis. The disease-causing capabilities of the different forms of asbestos depend on concentration, size, shape, and solubility. Asbestos occurs in two distinct geometric forms, serpentine and amphibole. The serpentine chrysotile form accounts for 90% of the asbestos used in industry. Amphiboles, even though less prevalent, are more pathogenic than chrysotiles, particularly with respect to induction of mesothelioma, a malignant tumor derived from the lining cells of pleural surfaces described later. The greater pathogenicity of amphiboles is apparently related to their aerodynamic properties and solubility. Chrysotiles, with their more flexible, curled structure, are likely to become impacted in the upper respiratory passages and removed by the mucociliary elevator. Furthermore, once trapped in the lungs, chrysotiles are gradually leached from the tissues because they are more soluble than amphiboles. In contrast, the straight, stiff amphiboles may align themselves with the airstream and thus be delivered deeper into the lungs, where they can penetrate epithelial cells and reach the interstitium. Both amphiboles and serpentines are fibrogenic, and increasing doses are associated with a higher incidence of asbestos-related diseases. In contrast to other inorganic dusts, asbestos acts as a tumor initiator and a tumor promoter. Chapter 7. Some of its oncogenic effects are mediated by reactive free radicals generated by asbestos fibers, which preferentially localize in the distal lung, close to the mesothelial cells of the pleura. Toxic chemicals absorbed onto the asbestos fibers also likely contribute to the oncogenicity of the fibers. For example, the absorption of carcinogens in tobacco smoke onto asbestos fibers may be the basis for the remarkable synergy between tobacco smoking and the development of lung carcinoma in asbestos workers. Smoking also enhances the effect of asbestos by interfering with the mucociliary clearance of fibers. One study of asbestos workers found a 5-fold increase of lung carcinoma with asbestos exposure alone, while asbestos exposure and smoking together led to a 55-fold increase in the risk. Once phagocytosed by macrophages, asbestos fibers activate the inflammasome and stimulate the release of pro-inflammatory factors and fibrogenic mediators. The initial injury occurs at bifurcations of small airways and ducts, where asbestos fibers land, penetrate, and are directly toxic to pulmonary parenchymal cells. Macrophages, both. Diffuse interstitial restrictive disease is 695. Alveolar and interstitial. Attempt to ingest and clear the fibers. Long-term deposition of fibers and persistent release of mediators, for example, reactive oxygen species, proteases, cytokines, and growth factors eventually lead to generalized interstitial pulmonary inflammation and fibrosis. Morphology. Asbestosis is marked by diffuse pulmonary interstitial fibrosis, which is distinguished from diffuse interstitial fibrosis resulting from other causes only by the presence of asbestos bodies. Asbestos bodies are golden brown, fusiform or beaded rods with a translucent center that consist of asbestos fibers coated with an iron-containing proteinaceous material Fig. 15.20. They arise when macrophages phagocytose asbestos fibers. The iron is presumably derived from phagocyte ferritin. Other inorganic particulates may become coated with similar iron-protein complexes and are called ferruginous bodies. Asbestosis begins as fibrosis around respiratory bronchioles and alveolar ducts and extends to involve adjacent alveolar sacs and alveoli. The fibrosis distorts the architecture, creating enlarged airspaces enclosed by thick fibrous walls. Eventually, the affected regions become honeycomb. The pattern of fibrosis is histologically similar to that seen in usual interstitial fibrosis, with fibroblastic foci and varying degrees of fibrosis. In contrast to co-workers pneumoconiosis and silicosis, asbestosis begins in the lower lobes and subplurally, with the middle and upper lobes becoming affected as fibrosis progresses. Scarring may trap and narrow pulmonary arteries and arterioles, causing pulmonary hypertension and cor pulmonale. Pleural plaques, the most common manifestation of asbestos exposure, are well-circumscribed plaques of dense collagen that are often calcified. Fig. 15.21. They develop most frequently on the anterior and posterolateral aspects of the parietal pleura and over the domes of the diaphragm. The size and number of pleural plaques do not correlate with the level of exposure to asbestos or the time since exposure. They also do not contain identifiable asbestos bodies. However, only rarely do they occur in individuals without a history or evidence of asbestos exposure. Uncommonly, asbestos exposure induces pleural effusions, which are usually serous but may be bloody. Rarely, diffuse visceral pleural fibrosis may occur in advanced cases, bind the lung to the thoracic wall. Figure 15.21. Asbestos-related pleural plaques. Large, Discrete fibroconcyphic plaques are seen on the pleural surface of the diaphragm. Courtesy Dr. John Godolsky, Brigham and Women's Hospital, Boston, Mass. Both lung carcinomas and mesotheliomas pleural and peritoneal develop in workers exposed to asbestos. See sections on carcinomas and pleural tumors. Clinical features. The clinical findings in asbestosis are very similar to those caused by other diffuse interstitial lung diseases discussed earlier. They rarely appear fewer than 10 years after first exposure and are more common after 20 to 30 years. Dyspnea is usually the first manifestation. At first, it is provoked by exertion, but later is present even at rest. Cough associated with production of sputum, when present, is likely to be due to smoking rather than asbestosis. Chest X-ray studies reveal irregular linear densities, particularly in both lower lobes. With advancement of the pneumoconiosis, a honeycomb pattern develops. The disease may remain static or progress to respiratory failure, cor pulmonale, and death. Pleural plaques are usually asymptomatic and are detected on radiographs as circumscribed densities. Asbestosis complicated by lung or pleural cancer is associated with a particularly grim prognosis. Key concepts. Pneumoconiosis. Pneumoconiosis encompasses a group of chronic fibrosing diseases of the lung resulting from exposure to organic and inorganic particulates, most commonly mineral dust. Pulmonary alveolar macrophages play a central role in the pathogenesis of lung injury by promoting inflammation and producing fibrogenic cytokines. Coal dust induced disease varies from asymptomatic anthocosis to simple coal workers, pneumoconiosis, coal macules or nodules, and centrilobular emphysema, to progressive massive fibrosis, manifested by increasing pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Silicosis is the most common pneumoconiosis in the world, and crystalline silica, for example, quartz is the usual culprit. The lung disease is progressive even after exposure stops. Chronic. Figure 15.20 high-power detail of an asbestos body, revealing the typical beating and knob ends arrow. 696 Chapter 15 The lung. The manifestations of silicosis range from asymptomatic silicotic nodules to large areas of dense fibrosis. Persons with silicosis also have an increased susceptibility to tuberculosis. There is twofold increased risk of lung cancer. Asbestos fibers come in two forms. The stiffened fibrils have a greater fibrogenic and carcinogenic potential than the SIRT. Pentene crystals. Asbestos exposure is linked with 6 disease processes. 1. Parenchymal interstitial fibrosis asbestosis. 2. Localized pleural. Plaques asymptomatic or rarely diffuse pleural fibrosis. 3. Recurrent pleural effusions. 4. Lung carcinoma. 5. Malignant pleural and peritoneal mesotheliomas. And 6. Laryngeal cancer. Cigarette smoking increases the risk of lung cancer in the setting of asbestos exposure. Even family members of workers exposed to asbestos are at increased risk for lung carcinoma and mesothelioma. Complications of therapies. Drug-induced lung diseases. An increasing number of prescription drugs have been found to cause a variety of acute and chronic alterations in lung structure and function, interstitial fibrosis, bronchiolitis obliterans, and eosinophilic pneumonia. For example, cytotoxic drugs used in cancer therapy, for example, bleomycin, cause pulmonary damage and fibrosis as a result of direct toxicity and by stimulating the influx of inflammatory cells into the alveoli. Amiodarone, a drug used to treat cardiac arrhythmias, is preferentially concentrated in the lung and causes significant pneumonitis in 5% to 15% of patients receiving it. Cough induced by angiotensin-converting enzyme inhibitors is very common. Illicit intravenous drug abuse most often causes lung infections. In addition, particulate matter used to cut drugs may lodge in the lung microvasculature, producing granulomatous inflammation and fibrosis. Radiation-induced lung diseases. Radiation pneumonitis is a well-known complication of radiotherapy for thoracic tumors, lung, esophageal, breast, mediastinal. Most often involves the lung within the radiation field and occurs in acute and chronic forms. Acute radiation pneumonitis, lymphocytic alveolitis, or hypersensitivity pneumonitis occurs 1 to 6 months after irradiation in 3% to 44% of patients, depending on dose and age. Manifests with fever, dyspnea out of proportion to the volume of lung irradiated, pleural effusion, and pulmonary infiltrates. Morphologic changes are those of diffuse alveolar damage associated with atypia of hyperplastic type Roman II pneumocytes and fibroblasts. Epithelial cell atypia and foam cells within vessel walls are also characteristic of radiation damage. With steroid therapy, these symptoms may resolve completely, but other cases progress to chronic radiation pneumonitis, pulmonary fibrosis, which also may occur without antecedent, clinically apparent, acute radiation pneumonitis. In its most severe form, chronic radiation pneumonitis and associated progressive fibrosis can lead to cyanosis, pulmonary hypertension, and cor pulmonale. Granulomatous diseases. Sarcoidosis. Sarcoidosis is a systemic granulomatous disease of unknown cause that may involve many tissues and organs. Its various clinical presentations are protein, but the most common are bilateral hilar lymphadenopathy or parenchymal lung involvement, occurring in 90% of cases. Eye and skin lesions are next in frequency. 6 other diseases, including mycobacterial and fungal infections and borreliosis, can also produce non-caseating granulomas. The diagnosis is one of exclusion. Sarcoidosis usually occurs in adults younger than 40 years of age but can affect any age group. The prevalence is higher in women but varies widely in different countries and populations. In the United States, the rates are highest in the Southeast and are 10 times higher in African Americans than in Caucasians. In contrast, the disease is rare among the Chinese and Southeast Asians. Patterns of organ involvement also vary with race. Pathogenesis. Although several lines of evidence suggest that sarcoidosis is a disease of disordered immune regulation in genetically predisposed individuals, its etiology is unknown. There are several immunologic abnormalities in the local milieu of sarcoid granulomas that suggest a cell-mediated immune response to an unidentified antigen. These abnormalities include intraalveolar and interstitial accumulation of CD4 plus T cells, resulting in CD4/CD8 T cell ratios ranging from 1 to 15, 1, suggesting pathogenic involvement of CD4 plus helper T cells. There is oligoclonal expansion of T cell subsets as determined by analysis of T cell receptor rearrangement, consistent with an antigen-driven proliferation. Increased levels of T cell derived from cytokines such as IL-2 and interferon IFN gamma, which may be responsible for T cell expansion and macrophage activation, respectively. Increased levels of several cytokines in the local environment IL-8, TNF, macrophage inflammatory protein 1 alpha that favor recruitment of additional T cells and monocytes and contribute to the formation of granulomas. TNF in particular is released at high levels by activated alveolar macrophages, and the TNF concentration in the bronchoalveolar fluid is a marker of disease activity. Impaired dendritic cell function. Additionally, there are systemic immunologic abnormalities in individuals with sarcoidosis. Both allergy to common skin test antigens, such as Candida or tuberculosis purified protein derivative PPD, and polyclonal hypergamma another manifestation of helper T cell dysregulation, are frequently observed. Evidence of genetic influences includes familial and racial clustering of cases and their association with certain human leukocyte antigen HLA genotypes, for example, HLA-A and HLA-B. Morphology. Virtually every organ in the body has been described as being affected by sarcoidosis, at least on rare occasions. Involved tissues contain well-formed non-necrotizing granulomas Fig. 15.22. Composed of aggregates of tightly clustered epithelioid macrophages, often with giant cells. Central necrosis is unusual. With chronicity, the granulomas may become enclosed within fibrous rims or may eventually be replaced by hyaline fibrous scars. Diffuse interstitial restrictive disease is 697, slightly braided and scaling, resembling those of systemic lupus erythematosus. Lesions may also appear on the mucous membranes of the oral cavity, larynx, and upper respiratory tract. Other patients present with erythema nodosum, painful erythematous nodules on the shins that stem from septal panniculitis. Ocular involvement, seen in 25% of cases, takes the form of iritis or iridocyclitis and may be bilateral or unilateral. Consequently, corneal opacities, glaucoma, and total loss of vision may occur. These ocular lesions are frequently accompanied by inflammation of the lacrimal glands and suppression of lacrimation-Sicca syndrome. Bilateral sarcoidosis of the parotid, submaxillary, and sublingual glands constitutes the combined uveoporotic involvement designated as Mikulicz syndrome chapter 16. Muscle involvement is underdiagnosed, since it may be asymptomatic. Muscle weakness, aches, tenderness, and fatigue should prompt consideration of occult sarcoid myositis, which can be diagnosed by muscle biopsy. Sarcoid granulomas occasionally occur in the heart, kidneys, central nervous system neurosarcoidosis, seen in 5% to 15% of cases, in endocrine glands, particularly in the pituitary, as well as in other body tissues. Figure 15.22 bronchus with characteristic non-casating sarcoidal granulomas asterisks, with many multinucleated giant cells arrowheads. Note subepithelial location of granulomas. Laminated concretions composed of calcium and proteins known as Schulman bodies and stellate inclusions known as asteroid bodies are found within giant cells in approximately 60% of the granulomas. No characteristic. These microscopic features are not pathognomonic of sarcoidosis because asteroid and Schulman bodies may be encountered in other granulomatous diseases, for example, tuberculosis. The lung is a common site of involvement. Macroscopically, there is usually no demonstrable alteration, although in advanced cases coalescence of granulomas produces small nodules that are palpable or visible as 1 to 2 cm, non-casating, non-cavitated consolidations. The lesions are distributed primarily along the lymphatics around bronchi and blood vessels, although alveolar lesions and pleural involvement are also seen. The relatively high frequency of granulomas in the bronchial submucosa accounts for the high diagnostic yield of bronchoscopic biopsies. There seems to be a strong tendency for lesions to heal in the lungs, so varying stages of fibrosis and hyalinization are often found. Lymph nodes are involved in almost all cases, particularly the hilar and mediastinal nodes, but any node in the body may be affected. Nodes are characteristically enlarged, discrete, and sometimes calcified. Consular granulomas are seen in about 1/4 to 1/3 of cases. The spleen is involved in about 75% of cases, but overt splenomegaly is seen in only 20% of cases. On occasion, granulomas may coalesce to form small nodules that are visible macroscopically. The liver is affected slightly less often than the spleen. It may be moderately enlarged and typically contains scattered granulomas, more in portal triads than in the lobular parenchyma. The bone marrow is involved in about 20% of cases. Radiologically, visible bone lesions have a particular tendency to involve phalangeal bones of the hands and feet, creating small circumscribed areas of bone resorption within the marrow cavity and a diffuse reticulated pattern throughout the cavity, with widening of the bony shafts or new bone formation on the outer surfaces. Skin lesions, encountered in 25% of cases, assume a variety of appearances, including discrete subcutaneous nodules, focal, slightly elevated, erythematous plaques, or flat lesions that are clinical features because of its varying severity and inconstant tissue distribution. Sarcoidosis may present with diverse features. It may be discovered unexpectedly on routine chest films as bilateral hilar adenopathy or may present with peripheral lymphadenopathy, cutaneous lesions, eye involvement, splenomegaly, or hepatomegaly. In the great majority of cases, however, individuals seek medical attention because of the insidious onset of respiratory abnormalities, shortness of breath, cough, chest pain, hemoptysis, or constitutional signs and symptoms, fever, fatigue, weight loss, anorexia, night sweats. Sarcoidosis follows an unpredictable course. It may be inexorably progressive or marked by periods of activity interspersed with remissions, sometimes permanent, that may be spontaneous or induced by steroid therapy. Overall, 65% to 70% of affected patients recover with minimal or no residual manifestations. 20% have permanent loss of some lung function or some permanent visual impairment. Of the remaining 10% to 15%, some die of cardiac or central nervous system damage, but most succumb to progressive pulmonary fibrosis and cor pulmonale. Key concept: sarcoidosis. Sarcoidosis is a multisystem disease of unknown etiology. The diagnostic histopathologic feature is the presence of non-casating granulomas in various tissues. Immunologic abnormalities include high levels of CD4 plus T cells in the lung that secrete phone-dependent cytokines such as IFN gamma and IL-2 locally. Clinical manifestations include lymph node enlargement, eye involvement, Sika syndrome, dry eyes, neuritis, or iridocyclitis. Skin lesions, for example, erythema nodosum, and visceral liver. Skin, marrow involvement. Lung involvement occurs in 90% of cases, with formation of granulomas and interstitial fibrosis. Chronic. 698 Chapter 15 The lung. Hypersensitivity pneumonitis. The term hypersensitivity pneumonitis describes a spectrum of immunologically mediated, predominantly interstitial lung disorders caused by intense, often prolonged exposure to inhaled organic antigens. Affected individuals have an abnormal sensitivity or heightened reactivity to the causative antigen, which, in contrast to asthma, leads to pathologic changes that primarily involve the alveolar walls, thus the synonym extrinsic allergic alveolitis. It is important to recognize these diseases early in their course because progression to serious chronic fibrotic lung disease can be prevented by removal of the environmental agent. Most commonly, hypersensitivity results from the inhalation of organic dust-containing antigens made up of the spores of thermophilic bacteria, fungi, proteins, or bacterial products. Numerous syndromes are described, depending on the occupation or exposure of the individual. Farmer's lung results from exposure to dust generated from humid, warm, newly harvested hay that permits the rapid proliferation of the spores of thermophilic actinomycetes. Pigeon breeder's lung. Bird fancier's disease is provoked by proteins from serum, excreta, or feathers of birds. Humidifier or air conditioner lung is caused by thermophilic bacteria in heated water reservoirs. Pet birds in moldy basements are easily missed unless asked about specifically. Several lines of evidence suggest that hypersensitivity pneumonitis is an immunologically mediated disease. Bronchoalveolar lavage specimens from the acute phase show increased levels of pro-inflammatory chemokines such as macrophage inflammatory protein 1-alpha and IL-8. Bronchoalveolar lavage specimens also consistently demonstrate increased numbers of both CD4 plus and CD8 plus T lymphocytes. Most patients have specific antibodies against the causative antigen in their serum. Complement and immunoglobulins have been demonstrated within vessel walls by immunofluorescence. The presence of non-necrotizing granulomas in 2/3 of the patients suggests that T-cell mediated type Roman 4 hypersensitivity reactions against the implicated antigens have a pathogenic role. Morphology. Histologic changes depend on the phase of the disease. Acute alveolar damage is seen in the first hours and few days after antigen exposure, while subacute changes are characteristically centered on bronchioles. They include interstitial pneumonitis, consisting primarily of lymphocytes, plasma cells, and macrophages. Eosinophils are rare, as well as non-necrotizing granulomas. Fig. 15.23. Interstitial fibrosis with fibroblastic foci, honeycombing, and obliterative bronchiolitis together with granulomas is seen in the chronic phase. Clinical features. The clinical manifestations are varied. Acute attacks, which follow inhalation of antigenic dust in sensitized patients, consist of episodes of fever, dyspnea, cough, and leukocytosis. Micronodular interstitial infiltrates may appear in the chest radiograph, and pulmonary function tests show an acute restrictive disorder. Symptoms usually appear 4 to 6. Figure 15.23 Hypersensitivity pneumonitis. Loosely formed interstitial granulomas and chronic inflammation are characteristic. Hours after exposure and may last for 12 hours to several days. They recur with re-exposure. If exposure is continuous and protracted, a chronic form of the disease supervenes, leading to progressive fibrosis, dyspnea, and cyanosis, a picture similar to that seen in other forms of chronic interstitial disease. Pulmonary eosinophilia. Although relatively rare, there are several clinical and pathologic pulmonary entities that are characterized by an infiltration of eosinophils, recruited in part by elevated alveolar levels of eosinophil attractants, such as IL-5. Pulmonary eosinophilia is divided into the following categories. Acute eosinophilic pneumonia with respiratory failure. This is an acute illness of unknown cause. It has a rapid onset with fever, dyspnea, and hypoxemic respiratory failure. The chest radiograph shows diffuse infiltrates, and bronchoalveolar lavage fluid contains more than 25% eosinophils. Histology shows diffuse alveolar damage and many eosinophils. There is a prompt response to corticosteroids. Secondary eosinophilia, which occurs in a number of parasitic, fungal, and bacterial infections, in hypersensitivity pneumonitis, in drug allergies, and in association with asthma, allergic bronchopulmonary aspergillosis, or Churg-Strauss syndrome, a form of vasculitis. Idiopathic chronic eosinophilic pneumonia, characterized by focal areas of cellular consolidation of the lung substance distributed chiefly in the periphery of the lung fields. Prominent in these lesions are aggregates of lymphocytes and eosinophils within the septal walls and the alveolar spaces. Interstitial fibrosis and organizing pneumonia are often present. These patients have cough, fever, night sweats, dyspnea, and weight loss, all of which respond to corticosteroid therapy. Chronic eosinophilic pneumonia is diagnosed when other causes of pulmonary eosinophilia are excluded. Smoking-related interstitial diseases. Smoking-related diseases can be grouped into obstructive diseases, emphysema, and chronic bronchitis. Already, chronic diffuse interstitial restrictive disease is 699. Discussed and restrictive or interstitial diseases. A majority of individuals with idiopathic pulmonary fibrosis are smokers. However, the role of cigarette smoking in its pathogenesis has not been clarified yet. Desquamative interstitial pneumonia and respiratory bronchiolitis. Associated interstitial lung disease are two others. Smoking-associated interstitial lung disease is worthy of brief mention. Desquamative interstitial pneumonia. Desquamative interstitial pneumonia is characterized by large collections of macrophages in the air spaces of a current or former smoker. The macrophages were originally thought to be desquamated pneumocytes. Thus the misnomer desquamative interstitial pneumonia. Respiratory bronchiolitis. Associated interstitial lung disease. Respiratory bronchiolitis. Associated interstitial lung disease is marked by chronic inflammation and peribronchial fibrosis. It is a common histologic lesion in cigarette smokers. It is characterized by the presence of pigmented intraluminal macrophages within first and second order respiratory bronchioles. In its mildest form, it is most often an incidental finding in the lungs of smokers or ex-smokers. The term respiratory bronchiolitis, associated interstitial lung disease, is used for patients who develop significant pulmonary symptoms, abnormal pulmonary function, and imaging abnormalities. Morphology. Morphology: the changes are patchy at low magnification and have a bronchiolocentric distribution. Respiratory bronchioles, alveolar ducts, and parabroncholar spaces contain aggregates of dusty brown macrophages, smokers' macrophages similar to those seen in desquamative interstitial pneumonia. There is a patchy submucosal and parabroncholar infiltrate of lymphocytes and histocytes. Mild parabroncholar fibrosis is also seen, which expands contiguous alveolar septum. Central lobular emphysema is common but not severe. Desquamative interstitial pneumonia is often found in different parts of the same lung. The most striking finding is the accumulation of a large number of macrophages with abundant cytoplasm containing dusty brown pigment, smokers' macrophages, in the airspaces. Fig. 15.24. Some of the macrophages contain lamellar bodies composed of surfactant within phagocytic vacuoles, presumably derived from necrotic type Roman II pneumocytes. The alveolar septa are thickened by sparse inflammatory infiltrate of lymphocytes, plasma cells, and occasional eosinophils. The septa are lined by plump, cuboidal pneumocytes. Interstitial fibrosis, when present, is mild. Emphysema is often present. Desquamative interstitial pneumonia usually presents in the 4th or 5th decade of life and is now equally common in men and women. Virtually all patients are cigarette smokers. Presenting symptoms include an insidious onset of dyspnea and dry cough over weeks or months, often associated with clubbing of digits. Pulmonary function tests usually show a mild restrictive abnormality and moderately decreased diffusing capacity. Patients with desquamative interstitial pneumonia typically have an excellent response to steroid therapy and cessation of smoking, but occasionally patients progress to interstitial fibrosis. Figure 15.24. Desquamative interstitial pneumonia. Medium power detail of lung demonstrates the accumulation of large numbers of macrophages within the alveolar spaces and only mild fibrous thickening of the alveolar walls. Symptoms are usually mild, consisting of gradual onset of dyspnea and cough in patients who are typically current cigarette smokers with exposures of over 30 pack years in the 4th or 5th decade of life. Cessation of smoking usually results in improvement. Pulmonary Langerhans cell histiocytosis. Pulmonary Langerhans cell histiocytosis is a rare disease characterized by focal collections of Langerhans cells, often accompanied by eosinophils. As these lesions progress, scarring occurs, leading to airway destruction and alveolar damage that result in the appearance of irregular cystic spaces. Imaging of the chest shows characteristic cystic and nodular abnormalities. Langerhans cells are immature dendritic cells with grooved, indented nuclei and abundant cytoplasm. They are positive for SON100, C-donia, and 207 Langerhans and are negative for CD68. More than 90% of affected patients are relatively young adult smokers or ex-smokers. Among smokers, about half improve after smoking cessation, suggesting that in some cases the lesions are a reactive inflammatory process. However, in other cases the Langerhans cells have activating mutations in the serine/threonine kinase BRAF, a feature consistent with a neoplastic process that is also commonly seen in Langerhans cell histiocytosis involving other tissues. Chapter 13. Neoplastic basis may explain why the disease progresses in some patients, sometimes even necessitating lung transplantation. Pulmonary alveolar proteinosis. Pulmonary alveolar proteinosis (PAP) is a rare disease caused by defects in pulmonary macrophage function due 700 Chapter 15 the lung to deficient granulocyte macrophage colony stimulating factor GM-CSF signaling, which results in the accumulation of surfactant in the intra-alveolar and broncholar spaces. PAP is characterized radiologically by bilateral patchy asymmetric pulmonary opacifications. There are 3 distinct classes of disease: autoimmune, formerly called acquired, secondary, and congenital, each with a similar spectrum of histologic changes. Autoimmune PAP is caused by autoantibodies that bind and neutralize the function of GM-CSF. It occurs primarily in adults, represents 90% of all cases of PAP, and lacks any familial predisposition. Knockout of the GM-CSF gene in mice induces PAP, and these mice are cured by treatment with GM-CSF. Loss of GM-CSF signaling blocks the terminal differentiation of alveolar macrophages, impairing their ability to catabolize surfactant. Secondary PAP is uncommon and is associated with diverse diseases, including hematopoietic disorders, malignancies, immunodeficiency disorders, lysine protein intolerance, and inborn error of amino acid metabolism, and acute silicosis and other inhalational syndromes. It is speculated that these diseases somehow impair GM-CSF, dependent signaling or downstream events involved in macrophage maturation or function, again leading to inadequate clearance of surfactant from alveolar spaces. Hereditary PAP is extremely rare, occurs in neonates, and is caused by loss of function mutations in the genes that encode GM-CSF or the GM-CSF receptor. Morphology. The disease is characterized by the accumulation of intra-alveolar precipitates containing surfactant proteins, causing focal talk influent consolidation of large areas of the lungs with minimal inflammatory reaction. Fig. 15.25. As a consequence, there is a marked increase in the size and weight of the lung. The alveolar precipitate is pink, homogeneous, and periodic acid, stiff, positive, and contains cholesterol clefts and surfactant proteins which can be demonstrated by immunohistochemical stains. Ultrastructurally, the surfactant lamellin type Roman II pneumocytes are normal, in contrast to surfactant dysfunction disorders described next. Clinical features: adult patients, for the most part, present with cough and abundant sputum that often contains chunks of gelatinous material. Some have symptoms lasting for years, often with intermittent febrile illnesses caused by secondary pulmonary infections with a variety of organisms. Progressive dyspnea, cyanosis, and respiratory insufficiency may occur, but other patients follow a benign course with eventual resolution of the lesions. Whole lung lavage is the standard of care and provides benefit regardless of the underlying defect. GM-CSF therapy is safe and effective in more than half of patients with autoimmune PAP, and therapy directed at the underlying disorder may also be helpful. Primary disease is treated with GM-CSF replacement therapy, sometimes followed by allogeneic hematopoietic stem cell transplantation, which can be curative. Surfactant dysfunction disorders. Surfactant dysfunction disorders are diseases caused by diverse mutations in genes encoding proteins involved in surfactant trafficking or secretion. Clinical manifestations range from neonatal respiratory failure to adult-onset interstitial lung disease. The most commonly mutated genes are the following. ATP-binding cassette protein member 3 ABCA3 is the most frequently mutated gene in surfactant dysfunction disorders. Mutations in ABCA3 are associated with an autosomal recessive disorder that usually presents in the first few months of life with rapidly progressive respiratory failure followed by death. Less commonly, it comes to attention in older children and in adults with chronic interstitial lung disease. The second most commonly mutated gene in surfactant dysfunction disorders encodes surfactant protein C. This form has an autosomal dominant mode of inheritance and has a highly variable course. The third most commonly mutated gene in surfactant dysfunction disorders encodes surfactant protein B. This form has an autosomal recessive mode of inheritance. Typically, the infant is full-term and develops progressive respiratory distress shortly after birth. Death ensues between 3 and 6 months of age unless lung transplantation is performed. Morphology. There is a variable amount of intra-alveolar pink granular material, type Roman II pneumocyte hyperplasia, interstitial fibrosis, and alveolar simplification. Immunohistochemical stains show the lack of surfactant proteins C and B and their respective deficiencies. Ultrastructurally, abnormalities in lamellar bodies and type Roman II pneumocytes can be seen in all three. Small lamellar bodies with electron-dense cores are diagnostic for ABCA3 mutation Fig. 15.26. Diseases of vascular origin. Figure 15.25 pulmonary alveolar proteinosis. The alveoli are filled with a dense, amorphous, protein lipid granular precipitate, while the alveolar walls are normal. Pulmonary embolism and infarction. Pulmonary embolism is an important cause of morbidity and mortality, particularly in patients who are bedridden. Diseases of vascular origin 701. Hemodynamic compromise due to increased resistance to pulmonary blood flow caused by the embolic obstruction. Sudden death often ensues, largely as a result of the blockage of blood flow through the lungs. Death may also be caused by acute right-sided heart failure, acute cor pulmonale. Morphology. Figure 15.26 pulmonary alveolar proteinosis associated with mutation of the ABCA3 gene. An electron micrograph shows type II pneumocytes containing small surfactant lamella with electron-dense cores, an appearance that is characteristic of cases associated with ABCA3 mutations, but also in a wide range of conditions that are associated with hypercoagulability. Blood clots that occlude the large pulmonary arteries are almost always embolic in origin. The usual source, thrombi in the deep veins of the leg 95% of cases, and the magnitude of the clinical problem were discussed in Chapter 4. Pulmonary embolism causes more than 50,000 deaths in the United States each year. Its incidence and autopsy has varied from 1% in the general population of hospital patients to 30% in patients dying after severe burns, trauma, or fractures. It is the sole or major contributing cause of death in about 10% of adults who die acutely in hospitals. By contrast, large vessel pulmonary thrombosis are rare and develop only in the presence of pulmonary hypertension and heart failure. Pathogenesis. Pulmonary embolism usually occurs in patients with a predisposing condition that produces an increased tendency to clot thrombophilia. Patients often have cardiac disease or cancer or have been immobilized for several days or weeks prior to the appearance of a symptomatic embolism. Patients with hip fractures are at particularly high risk, hypercoagulable states, either primary, for example, factor V-laden, prothrombin mutations, and antiphospholipid syndrome, or secondary, for example, obesity, recent surgery, cancer, oral contraceptive use, pregnancy, are important risk factors. Indwelling central venous lines can be a nidus for formation of right atrial thrombi, which can embolize to the lungs. Rarely, pulmonary embolism may consist of fat, air, or tumor. Small bone marrow embolia are often seen in patients who die after chest compressions performed during resuscitative efforts. The pathophysiologic response and clinical significance of pulmonary embolism depend on the extent to which pulmonary artery blood flow is obstructed, the size of the occluded vessels, the number of emboli, and the cardiovascular health of the patient. Emboli have two deleterious pathophysiologic consequences: respiratory compromise due to the non-perfused, although ventilated, segment, and large emboli lodge in the main pulmonary artery or its major branches or at the bifurcation as a saddle embolus Fig. 15.27. Smaller emboli travel out into the more peripheral vessels, where they may cause hemorrhage or infarction. In patients with adequate cardiovascular function, the bronchial arterial supply sustains the lung parenchyma. In this instance, hemorrhage may occur, but there is no infarction. In those in whom cardiovascular function is already compromised, such as patients with heart or lung disease, infarction is more likely. Overall, about 10% of emboli cause infarction. About 75% of infarcts affect the lower lobes, and in more than half, multiple lesions occur. They vary in size from barely visible to massive lesions involving large parts of a lobe. Typically, they extend to the periphery of the lung as a wedge with the apex pointing toward the hilus of the lung. In many cases, an occluded vessel is identified near the apex of the infarct. Pulmonary embolus can be distinguished from a postmortem clot by the presence of the lines of Zahn in the thrombus. Chapter 4. The pulmonary infarct is classically hemorrhagic and appears as a raised, red-blue area in the early stages Fig. 15.28. Often, the opposed pleural surface is covered by a fibrinous exudate. The red cells begin to lyse within 48 hours, and the infarct becomes paler and eventually red-brown as hemosiderin is produced. With the passage of time, fibrous replacement begins at the margins, as a gray-white peripheral zone, and eventually converts the infarct into a contracted score. Histologically, the hemorrhagic area shows ischemic necrosis of the alveolar walls, bronchioles, and vessels. If the infarct is caused by an infected embolus, the neutrophilic inflammatory reaction can be intense. Such lesions are referred to as septic infarcts, some of which turn into abscesses. Clinical features of large pulmonary embolus is one of the few causes of virtually instantaneous death. During cardiopulmonary resuscitation in such instances, the patient frequently is sent. Figure 15.27 large saddle embolus from the femoral vein lying astride the main left and right pulmonary arteries. From the teaching collection of the Department of Pathology, University of Texas Southwestern Medical School, Dallas, Texas. Chapter 15, the lung. Anticoagulation is contraindicated, may be fitted with an inferior vena cava filter and umbrella that catches clots before they reach the lungs. Figure 15.28 acute hemorrhagic pulmonary infarct. To have electromechanical dissociation, in which the electrocardiogram has a rhythm, but no pulses are palpated because no blood is entering the pulmonary arterial circulation. If the patient survives after a sizable pulmonary embolus, however, the clinical syndrome may mimic myocardial infarction, with severe chest pain, dyspnea, and shock. Small emboli are silent or induce only transient chest pain and cough. In the remaining group of patients with symptomatic pulmonary embolism, the most common presenting symptoms in descending order are dyspnea, pleuritic pain, and cough, accompanied in about half of cases by calf or thigh swelling or pain. Emboli that lead to pulmonary infarction may additionally produce fever and hemoptysis. An overlying fibrinous pleuritis may produce a pleural friction rub. In hemodynamically stable patients with a low to moderate risk of pulmonary embolism, D-dimer measurement is a useful screening test, as a normal D-dimer level excludes pulmonary embolism. Definitive diagnosis is usually made by computed tomographic pulmonary angiogram, which identifies obstructed pulmonary arteries. Rarely, other diagnostic methods, such as ventilation perfusion scanning, are required. Deep vein thrombosis can be diagnosed with duplex ultrasonography. Chest radiography may be normal or disclose a pulmonary infarct, usually 12 to 36 hours after it has occurred, as a wedge-shaped infiltrate. After the initial acute insult, emboli often resolve via contraction and fibrinolysis, particularly in relatively young patients. If unresolved, with time multiple small emboli may lead to pulmonary hypertension and chronic cor pulmonale. Perhaps most important is that a small embolus may presage a larger one. In the presence of an underlying predisposing condition, patients with a pulmonary embolus have a 30% chance of suffering a second embolus. Prevention of pulmonary embolism is a major clinical challenge for which there is no easy solution. Prophylactic therapy includes early ambulation in postoperative and postpartum patients, elastic stockings and graduated compression stockings for bedridden patients, and anticoagulation in high-risk individuals. Treatment of pulmonary embolism includes anticoagulation and supportive measures. Thrombolysis may have some benefit in patients with severe complications, for example, shock, but carries a high risk of bleeding. Those at risk of recurrent pulmonary embolism in home. Key concepts: pulmonary embolism. Almost all large pulmonary artery thrombi are embolic in origin, usually arising from the deep veins of the lower leg. Risk factors include prolonged bed rest, leg surgery, severe trauma, congestive heart failure, use of oral contraceptives, especially those with high estrogen content, disseminated cancer, and inherited forms of hypercoagulability. The vast majority, 60% to 80% of emboli, are clinically silent. A minority, 5%, cause acute cor pulmonale, shock, or death, typically from large saddle emboli, and the remainder cause symptoms related to ventilation perfusion mismatch and or pulmonary infarction, particularly dyspnea and pleuritic chest pain. Risk of recurrence is high, and recurrent embolism may eventually lead to pulmonary hypertension and cor pulmonale. Pulmonary hypertension. Pulmonary hypertension is defined as a mean pulmonary artery pressure greater than or equal to 25 mmHg at rest. Based on underlying mechanisms, the WHO has classified pulmonary hypertension into 5 groups. 1. Pulmonary arterial hypertension, a diverse collection of disorders that all primarily impact small pulmonary muscular arteries. 2. Pulmonary hypertension due to left heart failure. 3. Pulmonary hypertension due to lung diseases and or hypoxia. 4. Chronic thromboembolic pulmonary hypertension and other obstructions. And 5. Pulmonary hypertension with unclear and or multifactorial mechanisms. Pathogenesis. As can be gathered from the above classification, pulmonary hypertension has diverse causes even within each group. It is most frequently associated with structural cardiopulmonary conditions that increase either pulmonary blood flow, pulmonary vascular resistance, or left heart resistance to blood flow. Some of the more common causes are the following. Chronic obstructive or interstitial lung diseases, group 3. These diseases obliterate alveolar capillaries, increasing pulmonary resistance to blood flow and, secondarily, pulmonary blood pressure. Antecedent congenital or acquired heart disease, group 2. Mitral stenosis, for example, causes an increase in left atrial pressure and pulmonary venous pressure that is eventually transmitted to the arterial side of the pulmonary vasculature, leading to hypertension. Recurrent thromboemboli, group 4. Recurrent pulmonary emboli may cause pulmonary hypertension by reducing the functional cross-sectional area of the pulmonary vascular bed, which in turn leads to an increase in pulmonary vascular resistance. Autoimmune diseases, group 1. Several of these diseases, most notably systemic sclerosis, involve the pulmonary vasculature and or the interstitium, leading to increased vascular resistance and pulmonary hypertension. 702. Vascular origin. 703. Obstructive sleep apnea, group 3, is a common disorder that is associated with obesity and hypoxemia. It is now recognized to be a significant contributor to the development of pulmonary hypertension and cor pulmonale. Commonly, pulmonary hypertension is encountered in patients in whom all known causes are excluded. This is referred to as idiopathic pulmonary arterial hypertension and also falls into group 1 disease. However, idiopathic is a bit of a misnomer, as up to 80% of idiopathic cases, sometimes referred to as primary pulmonary hypertension, have a genetic basis, sometimes being inherited in families as an autosomal dominant trait. Within these families, there is incomplete penetrance, and only 10% to 20% of the family members actually develop overt disease. As is often the case, much has been learned about the pathogenesis of pulmonary hypertension by investigating the molecular basis of the uncommon familial form of the disease. The first mutation to be discovered in familial pulmonary arterial hypertension was in the gene encoding bone morphogenetic protein receptor type 2 BMP-ARPL. Inactivating germline mutations in the BMP-ARPL gene are found in 75% of the familial cases of pulmonary hypertension and 25% of sporadic cases. Subsequently, other mutations have been discovered that also converge on the BMP-ARPL pathway and affect intracellular signaling. It has also been demonstrated that BMP-ARPL is downregulated in lungs from some patients with idiopathic pulmonary arterial hypertension without BMP-ARPL mutations. BMP-ARPL is a cell surface protein belonging to the TGF-beta receptor superfamily, which binds a variety of cytokines, including TGF-beta, bone morphogenetic protein BMP, activin, and inhibin. Originally described as a pathway that regulates bone growth, BMP-ARPL signaling is now known to be important for embryogenesis, apoptosis, and cell proliferation and differentiation. Details remain to be worked out, but it appears that haploinsufficiency for BMP-ARPL leads to dysfunction and proliferation of endothelial cells and vascular smooth muscle cells. Because only 10% to 20% of individuals with BMP-ARPL mutations develop disease, it is likely that modified genes and/or environmental triggers also contribute to the pathogenesis of the disorder. A two-hit model has been proposed whereby a genetically susceptible individual with a BMP-ARPL mutation requires additional genetic or environmental insults to develop the disease. Fig. 15.29. Morphology. All forms of pulmonary hypertension are associated with medial hypertrophy of the pulmonary muscular and elastic arteries and right ventricular hypertrophy. The presence of many organizing or recanalized thrombi favors recurring pulmonary embolia as the cause, and the coexistence of diffuse pulmonary fibrosis or severe emphysema and chronic bronchitis. Points to chronic hypoxia and loss of capillary beds as initiating events. The vessel changes can involve the entire arterial tree, from the main pulmonary arteries down to the arterioles. Fig. 15.30. In the most severe cases, the thickening of the walls of the pulmonary artery and its major branches take on some features of systemic atherosclerosis, when classic atherosclerotic changes are not seen. Instead, the arterioles and small arteries 42-233 modified genes, BMP-ARPL locus, mutations, pulmonary vascular thickening and occlusion, primary pulmonary hypertension. Figure 15.29 Pathogenesis of primary idiopathic pulmonary hypertension. See text for details. 300 mm in diameter are prominently affected by striking medial hypertrophy and intimal fibrosis, sometimes narrowing the lumens. Pinpoint channels. One extreme in the spectrum of pathologic changes is the plexiform lesion, so called because a tuft of capillary formations is present, producing a network, or web, that spans the lumens of dilated thin-walled, small arteries and may extend outside the vessel. Plexiform lesions are most prominent in idiopathic and familial pulmonary hypertension group 1, unrepaired. Congenital heart disease with left or right shunts group 2. Pulmonary hypertension associated with human immunodeficiency. Virus HIV infection and drugs also group 1 diseases. Clinical features. Idiopathic, often inherited forms of pulmonary hypertension are most common in women who are 20 to 40 years of age, but may occasionally present in childhood. Clinical signs and symptoms in all types become evident only in advanced disease. In cases of idiopathic disease, the presenting features are usually dyspnea and fatigue, but some patients have chest pain of the anginal type. Over time, severe respiratory distress, cyanosis, and right ventricular hypertrophy occur, and death from decompensated cor pulmonale, often with superimposed thromboembolism and pneumonia, ensues within 2 to 5 years in 80% of patients. Treatment choices depend on the underlying cause. For patients with secondary disease, therapy is directed at the trigger, for example, thromboembolic disease or hypoxemia. A variety of vasodilators have been used with varying success in those with group 1 or refractory disease belonging to other groups. Lung transplantation provides definitive treatment for selected patients. Diffuse pulmonary hemorrhage syndromes. Pulmonary hemorrhage is a dramatic complication of some interstitial lung disorders. Pulmonary hemorrhage syndromes. Environmental triggers. 704 Chapter 15 The lung, AB, has been reported in adults as well. It usually presents with an insidious onset of productive cough, hemoptysis, and anemia associated with diffuse pulmonary infiltrates. The cause and pathogenesis are unknown, and anti-basement membrane antibodies, the cause of Goodpasture syndrome, are undetectable. However, favorable response to long-term immunosuppression with